So if we move on to the next slide, please, Chris. And this is our agenda for the week. This is the fantastic campaign that's been built for us for this week. The fantastic program for this week. You see, really comprehensive. You know, today's conference is only a small part of what's out there and what's available. Really ranging across the system about all of the different work that's being done for us, for children and young people with asthma, and by all of us here and across the system across London. So we've got blogs and podcasts. We've got some fantastic webinars as well. We can put a link into the chat for the agenda, and the agenda's got hyperlinks on it. So if anyone wants to actually get involved or join something, there'll be hyperlinks within the week's agenda that will take you to more information, with all of the information available around how to access these. So I can let you know certainly that the podcasts are, a number of them are up already. They're available on iTunes, through SoundCloud, and again they're tweeted about on a daily basis. So if you keep an eye on the Healthy London at Healthy LDN for further information on a daily basis, it's all been tweeted about. So yeah, I'm sure you'll agree a sort of fantastic range of stuff that's out there. So let's move on to the work for today. Next slide, please. I suppose I probably should have started by introducing myself. My name's Oliver Anglin. I'm a GP. I am the children's lead for North Central London, and also for the purposes of today, I'm the children and young people's asthma lead for the Healthy London Partnership, and I chair the London Asthma Leadership and Innovation Group. So hence me being at the front, the virtual front today to talk to you all. And obviously this is a hugely important condition that we're here to discuss then, to talk about. And this question of why are we here today? Well, this is why we're here today. There are over 200,000 children and young people living with asthma in London right now, and this is a long-term condition. It's a condition which is eminently manageable, and yet we still keep seeing all of these kind of statistics that we see here, with over 4,000 unplanned hospital admissions for children with asthma, the majority of which were preventable. A really significant number of call-outs for utilisation of ambulance services. These kind of frequent usage and attendance at emergency departments, and of course at the bottom there, the absolute tragedy that we have a manageable condition from which children and young people need to die in the capital. So the problem is real. It's a significant, very common long-term conditions with potentially very serious consequences. So that's why we're here, and this is the problem. Can I have the next slide, please, Chris? The other reason why we're here is to talk about the solution, and so what is the solution? And the answer to that is we are the solution. This work that we are doing together is the solution. Coming together in this way today, highlighting across London the importance of asthma as a condition, and pulling together across all elements of the system in order to respond to it. We're already seeing some fantastic work that's being done with great examples across the capital. Stuff happening with asthma-friendly schools, the development of asthma networks, fantastic data platforms such as Wizic, the great work and the increasing number of clinical nurse specialists working across London, as well as the work that's being done by the STPs as well. And I think this is a real key part of it. So we all recognize now that asthma is not just a medical problem. Asthma is a multifactorial problem. There are many different factors that will feed into the condition and the kind of consequences of having to live with that condition. Everything from, you know, how well trained the medical staff are, all the way through to what's the kind of socio-economic background of children. And we know that a child from lower socio-economic background is twice as likely to end up in hospital with the same level of asthma. So the solution is a whole system response, and that's why, you know, that's what we're working towards with all of this fantastic work that's being started, and also part of why we're all coming together today to work together as a system to respond to this condition as a system, and to raise awareness of this condition as a system. So you know, really important conference today, with some fantastic work to share and talk about. So with that said, we'll move on to Bill. Yeah, sorry, this was thanks, Chris. I'd forgotten we talked about this. So there's a menti.com. We're going to do a Mentimeter later on, and this is basically just to try and get some feedback from you guys, try and get a real sense of what people are taking away from this conference today, from everything that they've heard and learned. So if you do have to leave early, it'd be really helpful if you could just make a note of the menti.com and the code, and you could, when you do leave, just if you could log into that, leave us your feedback on that, or leave us your comment, what you're taking away from Mentimeter, and that will sort of feed into our result at the end. So thanks, Chris. So we'll move on to our first speaker. Gives me great pleasure to welcome Richard Isles, who will be talking about the fantastic work on the new London asthma standards. So with that, thank you very much for coming, Richard. Nice to see you, and I'll hand over to you.
Thank you, Oliver. Thumbs up if you can hear me. It'll be good. Great, thank you. So this is the first time I've done this, and we had a quick run through last week, but fingers crossed this is all going to work beautifully. So I'm going to share my screen, and hopefully you can see my screen now. So yes, my task today is to introduce the new London asthma standards. As you know, they were first produced in 2014. And also provide you with a brief clinical update. So the first,
Richard, sorry to interrupt. Can you go to slideshow so we can see it a bit bigger?
Yep, sure. View. Yeah, there's a. Yeah, got it. Hang on. Is that any better?
Yes, perfect.
Perfect. Thank you. It's flashing red. Is it meant to flash red? Right, let's give it a go. So
yes, that's fine. Don't worry about the red. It just means we're
Thank you. So the first thing to actually say is these have been produced and were actually initiated pre-COVID-19. So it was we collected the data and reviewed the documentation in the weeks and months before COVID-19, and our initial thoughts as we kind of came to publication is that this already is a relatively historic document. It's not to say it doesn't have any worth. It is extremely useful in terms of a collation of national and international documentation, but it does have a provision that in the next few months to years, we will have to rewrite them again, review them to look at the new normal and how we are planning to work in the new normal environment. And that will include probably guidance on how to run virtual clinics and virtual diagnostics, etc. So for the documentation, we used the Royal College of Physicians National Review of Asthma Deaths, the GINA Global Initiative, the National Institute for Healthcare and Excellence 2013, updated in 2019, which specifically looks at the quality standards for asthma. NICE 2017 with diagnosis and monitoring, and a BTS sign guidance. So the audience, this is meant to be used by commissioners and providers for asthma services for children and young people. And we were hoping before we actually published and before COVID that we would start to introduce a method of peer review and potentially but we can actually use these now whilst we get our heads around how we might want to do a peer review in the new world, to actually do self-assessments of individual units, and maybe we can collate those in over the next few months. So every child should have access to a named set of professionals that are trained in asthma care. Training, I think, will come through as one of the big themes of this document. We are very aware there are people who are currently in post who may not have the right training. How one achieves the right training at the moment, we are still working on, but we are clear that we would like people with the right background, interest, and experience to actually be part of these new asthma teams. We want families, and particularly in the COVID world, to manage their own asthma, and again, self-support and self-monitoring come in quite strongly, and grow up in an environment that's clean air and access to an environment that was rich in opportunities to exercise. And those themes are included in the NHS England NHSI 2019 Our Vision for London document. So every child with asthma should have their diagnosis and severity of wheeze established in a timely fashion with access to age-appropriate diagnostic services, have access to immediate medical care, advice and medicines in an emergency, and have access to high-quality evidence-based care from primary, secondary and tertiary healthcare professionals in a timely manner, 24 hours a day, 7 days a week. Every child should have an evidence-based asthma management plan, have a regular structured review, and that should be at least yearly or meet more frequently depending on their control. Have a structured review post-exacerbation in a timely, and we felt within 5 days at most, and again that should be led by an appropriately trained and experienced professional. Have access to a package of care that includes education, self-management tools, and access to peer support, and be able to expect all professionals to be involved in their shared care. And the ideal is that we have a shared digital care record in the future. There's also a chapter now on transition process from child to adult care, which I'll talk about in a few minutes. So the new standards, there are 45 standards, and they're split into organization of care, patient and family support, diagnostic and chronic care, schools, acute care, high-risk care, integration and care coordination, discharge, transition, effective and consistent prescribing, workforce and education training. And I'm going to go through not all of these, but just the ones where I think the emphasis has changed, or where the emphasis is part of what we're trying to create in terms of networks. So organization of care. Well, each STP-CYP transformation board should have or will have a named pediatric asthma lead with asthma expertise. All organizations and services must have a named lead with asthma expertise who is responsible and accountable for dissemination and implementation of asthma standards. And these leads should collaborate across their networks. Each ICS should have a pediatric asthma network, and each ICS should develop and maintain a pathway of referral. So we're no longer looking at units working in isolation, and we're looking at people forming an asthma network within the ICS. This is a relatively old slide because Katie from GOS has moved on to Bristol, but I think Oliver had a better slide showing the ICS geographic distributions. So patient and family support, information provision and expertise. Whenever inhalers are prescribed, patients should have received training in their use of the device and have demonstrated satisfactory technique. And that demonstration should be, as I keep harping on about, to someone who has the appropriate asthma background and expertise and interest. This then goes on to say, if a change of device is necessary, a pharmacist or other professional with appropriate training should advise the patients on its use. There's no point changing devices frequently or infrequently and not training people on how to use them. In diagnosis and chronic care, we appreciate that diagnosis can be difficult in children and young people, but children and young people with suspected asthma should be diagnosed on the basis of personal and family history in the first place, and that diagnosis then supported with objective measurements where they are available. And those objective measurements will include spirometry, peak flow diaries, FeNO, and also then, as asthma is a chronic condition, response to treatment. I think that we often get blinded by the new NICE diagnosis, which seems to emphasize a theme of the objective measurements, but it does include the statement, should be diagnosed on the basis of personal and family history. This is quite an important slide, and I urge you to kind of catch it when the slide set is available, or actually go to the asthma standards and use this as a self kind of as a checklist for a secondary care unit. But each clinic should have the capacity to see the number of children utilizing the service with appropriate times and lengths of waiting times. See GP referrals within 4 to 8 weeks. Should see children after discharge from the ward within 4 to 6 weeks. Identify children attending the ED with acute asthma, wheeze, and identify recurrent attenders of children at risk. They should be able to perform the diagnostics of spirometry, bronchodilator reversibility, and FeNO, and should perform consistent inhaler training, asthma education, and standardize within their own network. And they should be able to issue asthma action plans for home and school consistent with the network guidance. That secondary care unit should then fit into a referral pathway for allergy, psychology, and physiotherapy. We recognize that not all objectives in the BTS sign will be achieved by a secondary care unit, but it's very important that children have access to those facilities, and therefore the referral pattern should be defined. And that's to an allergy department, referral to psychology, and referral to physiotherapy. There should be either internal or external referral pathway for smoking cessation, and also a referral pathway potentially, well, preferably internally for safeguarding. I think there is a session, Louise Fleming has recorded a session within the Ask About Asthma week to have about referral pathways for tertiary care. Please dig that out. We are keen to encourage referrals to tertiary care where appropriate. We are keen not to have the usual pathway of A, B, C, D. We are keen to see people and children who are actually fulfilling the severe asthma tertiary pathway criteria rapidly. One of the data that I reviewed last year was that some children from primary to tertiary care, their pathway may take 6 or 7 years, which is actually half their lifetime, when the referral should have been probably within 6 months to a year if they had been triaged appropriately. So schools, all schools should have a register of children and young people with asthma. And again, within the school environment, there should be an individual responsible for asthma within that school. And they should have a system of identifying and taking appropriate action in the case of children who have poor control. And that could be notification with the permission of the parents to the GP. After all, schools often see more of the children during the active daytime periods than some of their parents. Acute care. All efforts should be made to support parents and children to engage with appointments utilizing community services, schools, nursing, etc. and we're really worried about safeguarding, and particularly in this new virtual environment about DNAs. And we are keen to actually emphasize that children who either are not brought or do not attend appointments with severe asthma or concerning asthma should be escalated within a within a safeguarding pathway. Children admitted to hospital with an acute exacerbation should have a structured review by a member of a specialist respiratory team. This appears in the BTS sign, I think, and also in the BTS discharge bundle. A specialist team, again, comes down to people who are actually trained and experienced in the care of asthma, and not just a checklist discharge bundle. So we would like at that review a ACT score, a review of the inhaler technique, self-management and how to manage acute exacerbations, a personalized asthma action plan, and also a recognition and optimization of modifier risk factors. If the child has had 2 or more acute attacks in the previous year, we would suggest a referral to a difficult or asthma center for an asthma clinical specialist review. Identifying high risks. This comes back to NICE, the NRAD. There should be a system in place in every bit of the pathway that identifies children at high risk or with poorly controlled or severe asthma. So just to go and remind you of those, if they've had 2 asthma attacks in the previous 12 months, any admission to HDU, ICU or PICU is recognized as a lifetime risk. 2 more attendances to the emergency department or out of hours care in the last year. 2 or more unscheduled visits to the GP, 6 or more salbutamol inhalers within a year, 80% or less uptake of repeat preventer prescriptions. So the last 2, getting the balance right between short-acting beta-2s and their inhaled corticosteroids is really important and identifies children at risk. We regularly see children who are running with moderate to severe asthma, who are running on salbutamol inhalers. When you get above 6 blue inhaler prescriptions per year, your risk of death increases quite significantly, according to the National Review of Asthma Deaths. Integration and care coordination. People with asthma receive a structured review by someone appropriately trained at least annually. Is part of the current guidance, and that includes the CN could not be brought or were not brought to clinics as part of a potential safeguarding review and should be included in the annual review. Discharge planning. Again, very important that the children have had discharge planning, and I think that was covered in the acute care. But again, going back through where the numbers of acute steroid usages, the number of ICS, and the number of SABAs that were picked up over 1 year would be important parts to try and stabilize the asthma, the child's asthma, and prevent further admissions. Transitional care. I think we've toiled with this over the years. Anybody with moderate to severe asthma should, and certainly within a severe asthma clinic, should be transitioned to a hospital-based asthma service. The hope and desire is that children with moderate or asthma or less should be probably transitioned within primary care. However, there should be a recognition that they have moved from childhood to adulthood in a seamless way. And that transition is potentially planned from the age of 14 onwards within the tertiary, secondary or tertiary asthma services. So I encourage you to dig deeper into the new standards. That was really just an overview looking at how we wish to kind of emphasize the need for networks and appropriate referral and guidance through the network systems. Onto the clinical update, and I think you'd all probably appreciate that over the last year or two that we have a feeling that there is too much guidance, and I quite like this approach that was viewed at the European Respiratory Society recently, that yes, we have GINA, but GINA is not really a guideline but an integrated evidence-based strategy, and in that context has a huge amount of worth. It is very soundly evidence-based and is a very important document at the moment. We have NICE that recommends treatments with an emphasis on cost and saving and efficiency, and we have SIGN and BTS, which is really a document that is the national endorsed guideline, which gives effective practice based on evidence. So, in fact, they all correct in their own context. But when we look at individuals, we should be looking at a personalized asthma management, which is an iterative process, and all people are different. So recognizing that asthma is a long-term condition, we constantly need to assess, adjust, and review a child's medication according to their stability, and not one size fits all. And it's not all about the medications. So our goal is probably, well, it is asthma control and improved control, which potentially reduces death and exacerbations, number of courses of oral corticosteroids. And it may not be around FEV1 and some of the other kind of outcome measurements. This appears in GINA. It is the new GINA document, which looks at a change, quite a dramatic change in step 1, moving to step 2, which is as needed low dose inhaled corticosteroids and formoterol for moderate asthma, for low only. And the reason for this is that a study showed a 64% reduction in severe exacerbations when this was used, compared with only a beta-2 agonist. And actually, this methodology resulted in 20% on average less inhaled corticosteroid dosage compared with daily ICS. So overall, quite an interesting concept, which one can see probably entering into the BTS SIGN guidance in a year or so's time. I don't know if many people, potentially quite a few people, went to the King's Conference recently, and I would encourage you to use this quite an innovative way of looking at asthma care by Will Carroll and how to recognize the most severe and uncontrolled asthmatics. And it's a mnemonic called UNSEEN. You always remember the unrecognized risk. That is enhanced if there is no plan. Try to assess the asthma severity, look at their environment, look at the excess SABA, and always look at their adherence. If you don't recognize the risk, the child has no plan, you haven't assessed the severity, you haven't looked at the environment, you haven't assessed the excess SABA usage, or looked at the non-adherence with ICS, that child is potentially at very high risk. Going on to publications, when I first thought about this last week or the week before, over the COVID period, I felt there had been quite a hold on all asthma publications, and the only publication I could really think of was the kind of joke publication from the New England Journal, which was Donald Trump use of commercial disinfectants to treat novel coronavirus method. Read the labels on the bottles when we found in the janitor's closet, and this will kill you. Please don't use it. The photos here were taken by a colleague of mine who took to riding for his own mental health, for riding around London on his bike and taking pictures of in COVID lockdown of basically deserted famous places, and I think they're actually quite beautiful. The one thing to note here is that pollution levels dropped quite dramatically, and I think I'll come on to that in a second. So this is from the European Respiratory Journal. It looks at the characteristics and outcomes of asthmatic patients. These are adults with COVID-19 pneumonia who required hospitalization. And when you get the slide set, please drill down into the flow diagrams. It's not to say that asthmatics in adulthood did not die, but their risk of death was associated with their comorbidities in adulthood. And so the worst outcomes were observed mainly in patients with major comorbidities. This is from the ERS last week, and it was a questionnaire, so not raw science, but sent out to all ERS members from the Pediatric Assembly during the period of March and April 2020. And from Europe and beyond, a total of 174 centres replied. 80 centres reported no cases in children, and 94 centres entered data from a total of 945 children with COVID. The age distribution, the sex distribution was roughly 50-50 boys and girls. And as you see, there were slightly higher 6 to 12-year-olds and over 12-year-olds than other age groups. Interesting, a 0 to 1 group was represented quite highly as well. The outcomes, presenting symptoms were interesting. A number were asymptomatic, a number had fever only, a number had upper respiratory tract infections, and a number had pneumonia, and only a few had an acute exacerbation of their asthma over and above the other symptoms. 30% were managed at home, 61% were managed on the ward, and 9% were admitted to a pediatric intensive care unit. And again, that was relatively based on comorbidities rather than their asthma. Again, looking what therapies they received, less than 4 out of 949 children received invasive ventilation. A number received oxygen, but many required no treatment. And that when they were given treatment, azithromycin and antibiotics seemed to be the majority, the main treatment prescribed. So again, hearsay rather than pure science. In New York, 11 asthmatics out of 46 children were admitted to the Bronx Hospital. Asthma was not associated with admission to PICU or a severe outcome. 1 asthmatic out of 40 children was admitted in Lombardy in Italy, and 1 asthmatic out of 34 children were admitted in West China, but that was associated with co-infection with what looked like a multitude of other viruses. The reference on the right appeared yesterday in thorax. Therefore, and again, it's reference to adult patients rather than kids. Therefore, optimizing asthma control versus optimizing medication adherence, minimizing the need for systemic steroids, avoidance of hospitalization, appears to be more important in COVID protection against COVID-19 than anything else. So if someone has well-controlled asthma, is not receiving systemic steroids, the chances of getting bad disease are probably quite small. What else? Well, from the ERS, it's quite interesting, and I think Richard Shavas has reported this in the BMJ as well. Over this year, we've seen a dramatic reduction in asthma admissions during lockdown. We have also seen a dramatic reduction in respiratory tract infections. However, the environmental triggers and pollutants, environmental triggers such as birch pollen and grass pollen remain the same. But the pollutants, one pollutant, certainly the NO2, reduced by less than half. So were people taking their medication more rigorously? Just avoiding viruses would seem to be a very good idea, and how we manage children and schools in the future when it comes to asthma may be an interesting concept. Do we still send our children to school when they have a snotty nose or are slightly wheezy, or do we hold them back in the future is for future debate, really. Interesting that pollutants dropped by more than half, and we didn't see that many asthma admissions over that period of time. Very complex interactions between psychosocial, therapeutic, and environmental, which I think we need a firm guidance on over the future year. We might get a firm guidance on over the future months. This is wonderful from The Guardian, looking at the COVID-19, and this was taken a week ago. And as you're probably aware, the rise in daily cases continues and looks to probably max or maybe go beyond max in week 38. So when we're asking about asthma, should we be asking about COVID and sending kids back to school, which is very important, but we're seeing potentially the same viral mix when people get together as we do with asthma, which triggers asthma admissions. So can we apply the same rules to COVID as we do for asthma? And I think it's really important that the message gets out that COVID is actually has different symptoms in children. And from Prof. Tim Spector at King's College, we have this obsession with fever, cough, and lack of smell in adults. But in children, symptoms, 55% had fatigue, and I'm seeing that in many of my follow-on clinics, that a lot of children still have this kind of chronic fatigue type syndrome. 54% had headaches. Almost half had fever, sore throats were present in around 38%, 35% skipped meals, and 15% had unusual skin rashes, and 13% had diarrhea. So this is a first concept of how we might choose to deliver care in a post-COVID world. And you can see at the bottom of a triangle, or first of all, on the left-hand side, we have uncontrolled and controlled. And if we are looking to really reach really efficient asthma care, we potentially want to see less of our controlled patients, but be able to identify and see more of our uncontrolled patients. In the bottom of the triangle at n equals 80%, we have a prescription of ICS beta-2 agonists and a spacer, but we always forget to prescribe and use a peak flow meter. And allowing people to self-manage in the post-COVID world with a peak flow meter and a diary and using an ACT score routinely would be very, very helpful. And I think this is about volume management with prescribable devices, and actually allowing self-management. And most of my patients in the mild to moderate group now have a peak flow meter and a diary, and will report back at our virtual clinics potentially an ACT score and their peak flow diary and their longitudinal measurements. Moving up, we're looking at virtual clinics with smart peak flow inhalers. And then right at the top, we're looking at issuing probably people with spirometry and potentially in the future, Pheno devices at home. That all turns into a fairly complex diagram where we are starting to look at how we can use Bluetooth smart devices over the internet to actually give us a longitudinal measurement of patients' well-being, combined with smart peak flow meters, smart spirometers combined with smart inhalers. So you get both the adherence data and the physiology data in one place. One last slide. This again was from Ian Sinner. This was again from Ian Sinner at the King's Conference that looks at COVID and health and economic fallout. And we are looking at quite a bad economic hit to potentially a percentage of society who was poorly off in the first place. So about 1 in 3 children in the UK live in relative poverty. In inner city London, that is probably higher. And we're looking at children and families who can't afford school meals, birthday parties, washed uniforms, and rely on food banks for food. And in the gig economy and zero-hour economy, it looks as though this is the part of the economy that's been badly hit by COVID. Odds ratios for developing asthma are antenatal stress, smoking, poverty and pollution, and obesity, all of which are related back to poverty. And we're also looking at a world where we're potentially creating a system, and becoming more and more aware of this, of digital poverty, where we're trying to implement virtual and digital platforms that might exclude patients where they have, and their families where they have no smartphone, no computer, no tablet, and no internet connection. And I'm not certain whether this group are the DNAs, CNAs, and there's a Venn diagram overview. But I think what we must be aware within the care of our asthma community is also the care of, there's also this problem with increasing poverty. So that is my last slide. I'm not quite sure I've how done for time, but I'm sure we can open up for questions.
Thanks so much, Richard. You've done fantastic for time. so great. Thank you for that. I was keeping tabs. So yeah, we've got some questions. Let's go with the hands. I'm just going to go with the hands first of all. Nell Knuckles, you've got your hand up. Do you want to ask your question?
Yes, thank you very much. Very interesting presentation. I'm glad it's recorded. There's so much on it. Thank you. I just want to note the excess of salbutamol, this SABA. Does the public understand that there is actually no inherent anti-inflammatory properties within that medication?
Oh, you just caught me, haven't you? Are you in the audience as a ringer for my kind of for me to rant now? Okay.
Pardon me?
So, no, I'm just saying you've just about to set me off on a rant. Okay, and those of you
that's
who
okay.
know me, I don't think many professionals know that either. So
it was reported just recently by AstraZeneca, and
I think and I'm also very disappointed to see a few weeks ago a TV personality doctor say that you can use as much beta-2 agonists as you like, when we know that there are dangers to this. So not just from the epidemiology, and I'm sure Mark's in the audience, Mark Levy, that when you look at the number of beta-2s, you can basically assign a risk to the overusage. But actually, if you go and drill down into the small print, you're absolutely right. There is no anti-inflammatory property to a beta-2 agonist. There is a danger of what's called tachyphylaxis, which is when the beta-2 receptors get full from a beta-2 agonist and they no longer function, and so you lose the functionality of the drug. And in some people, a beta-2 agonist in overusage is probably incites or creates airway inflammation. So you're actually looking at a drug which should be used according to the BNF guidance and should not be used in overusage at all. And I think that's not, you're absolutely right. It's not really understood by many healthcare professionals, including personality doctors on TV, and it's not really understood by most of the parents and kids. Thank you.
Thank you.
Thanks, Richard. I see Mark had his hand up there. Mark Levy. Mark, do you want to come in? You'll need to unmute yourself, Mark. Maybe we'll come back to you in a second, Mark. You're not unmuting. Arvind Shah.
Oh, hi, thank you so much. Richard, that was a fantastic presentation. Thank you for giving me the opportunity to ask a few questions. I think one of the things which is important, I think, is thinking out of the box. And I just want to understand from the group where we stand with connection with social services and social care and public health to integrate all together. If you're looking at like smoking cessation or psychological aspects and poverty and all that. So I really want guidance on this, please. I do work in a very deprived population, etc.
Yeah. I think when it comes, we've always been aware, but I think we should be more aware that and I've always looked for this measurement of chaos, which comes with poverty, comes with social movement, it comes with low income, that you are so stressed trying to make a day-to-day world work for you and your children that you may forget the routine things like asthma medications, etc. I think it is really important. I think one of the new things of integrating social services and health together is very good. Ian Sinner even went as far as to say, well, we have Costa Coffees in our hospitals. Why don't we have social services departments more readily and care facilities more available to parents and patients when they walk into in hospital? So I think it is time that we ought to integrate these more together. When I first started, we used to have a social worker actually on the team. We've now lost that. But I think we have to make every effort to kind of integrate more, particularly around these high-risk kids. I don't know if Oliver, you've got probably more insight into that as well.
Yeah, and I think we'll hear from speakers later on in the conference from the various STP areas about work that is happening to integrate the recognition that asthma is a socio-economic as well as a medical issue. So I'm sure you will hear some information about that, and I know there's good work going on in NCL, which if you're at North Mid will obviously be influencing your area as well. So we can keep you posted. We had I'm going to come to Mark in a second. There was a question in the chat from Sukeshi. So in terms of GINA guidelines and use of Symbicort, one of our stumbling blocks is that Symbicort MDI is only licensed for COPD in adults. Are you aware of any developments on use of ICS formoterol MDIs for use as smart therapy as per GINA?
No, but I've written to the MHRA regarding Ventolin for usage, and I'm happy to, once I get a reply, I would be happy to kind of include other kind of asthma products in that dialogue.
Great, thanks, Richard, and I'm sure Sukeshi can get in touch with you if she wants to be involved in that. Great, Mark Levy, you able to come back in again now? Okay. So Richard, so couple of things just from me. You mentioned the Louise Fleming conversation about tertiary pathways. So yeah, thanks for mentioning that. There's a podcast of myself interviewing Louise. So it was a really interesting conversation. So if people are interested in that, it's available in podcast form. You can click through the link on the week's agenda, or go to where you get your podcasts normally. I know some of the they're being released on a daily basis on the iTunes platform, for example. And I think just to reflect what you mentioned, Richard, and seems to have been a theme in a lot of conversations I was having around the difference between or the importance distinction here that to think about uncontrolled asthma rather than severe asthma. So, you know, we're not just talking about children who are on biologics because of their clinical severity, but we're talking about kind of the poor control for whatever reason, and the value of referring those up as well. Yeah. So great to hear.
I think it'd be wonderful if we could use the new technology to get to a place where you can highlight the uncontrolled group or the disappeared group, and then have the confirmation that there's another group that are going along in a very controlled way. Yeah. And that would be the way that I can see that services might be able to cope with the volume in a better way.
Yeah, fantastic. Thank you. So I think Sonia's just posted the link for the podcast on SoundCloud into the chat with regard. That was the tertiary one. So if anyone wants that, the link is there for you. Please make a note of it, or click through on it. And I think last question now in the chat. So I think this is from John Moreras. Are there any plans to do education on weaning another interesting contentious point.
So I think we need to reach a consensus about weaning as a consultant group before we can teach. I'm very aware that we have quite diverse differences of opinion across London. I think it would be quite useful probably if we got together and looked at the data. I know people are asking for a study to show that weaning protocols either are or are not effective, but I would make it very clear right at the start that a weaning protocol does not appear in any of the national or international documentation that has been published to date. So where units are using a weaning protocol for SABAs, then I think they are not necessarily following national evidence-based guidance in the first place. And why do we need a randomized controlled trial to see to actually support or refute something which has not got any evidence behind it already?
Yeah, interesting. Thank you, Richard. And so just a comment in the chat from Mark Levy. Gina says, at least advise patients to use ICS, an inhaled corticosteroid, whenever they use a SABA. I think this was going back to a previous point there. Yeah.
And it's a lovely extension of smart technique, etc. It's really sensible, I think, when it comes to looking at the non-inflammatory, potentially pro-inflammatory properties of short-acting beta-2s.
Yes, exactly. Great. Well, thanks for that, Richard. Really much
Pleasure.
appreciated. So this is all being recorded. So if anyone wants to share any of this, and the London standards, as I said, they're now, this new version of the standards is now released. This new version of the standards is now released. Oh, forgive me. Yeah, the new version of the standards is now released and available. So so thank you for that. So we're moving on to sorry, just before we move on to our next speaker, it's just a reminder, could I ask everyone, if you're not actually speaking, would you mind having your cameras off and being on mute? Having the cameras off helps us with bandwidth. So it's important, if you wouldn't mind, please making sure your cameras are off unless you're speaking. Thank you very much. So move on to our next speaker. This is really delighted to welcome Matthew Clark, who's the National Specialty Advisor for Children and Young People for NHS-E and I. So great to have you along, Matthew. Richard, could I ask you to stop sharing your screen, and we'll get Chris or Georgie will start sharing theirs instead.
I was going to share mine myself. If that's
great. Okay, fantastic.
If you'd rather I didn't, that's fine as well.
No, good for you to share, Matthew. No problem.
And hopefully, can you see that now?
Yeah, can see it
just
fine.
Because I still don't have complete faith in Microsoft Teams, despite a lot of our lives now being consumed by it. Okay. So Oliver, thanks very much, and thanks very much for inviting me to talk today at the Beat Asthma conference. I thought what I would do today is really just introduce a little bit to you about what the young people's transformation work at NHS England and Improvement, how it's evolved, how it's worked, how we thought it was going to work. Then give you a little bit of an update of how things have had to change in the last sort of 8 months for the very obvious reason of the COVID pandemic. And then at the end, just to share with you the sort of very embryonic stages of the work on paediatric asthma, and then a real invitation, because I know there's a huge amount of expertise in the delegates to this conference. So I'd really like to make sure that we have plenty of time at the end for people to kind of open up a discussion, and then I'm sure there'll be further meetings that we need to have. So I will kick off just by saying that the NHS long-term plan, which now feels like quite old news, but still very much shapes the long-term strategy of the NHS, made a very explicit commitment to children and young people within it. There was a particular focus on improving integrated care in the same way there is for adults, but also a commitment to support the 3 most common long-term conditions in children, which are diabetes, epilepsy, and as everyone on this call knows, asthma as well. And the commitment to really try and move us on from some outcomes which I think where we lag behind some of our European or peers. So really making sure that we're delivering, delivering for what children and young people need. So just in terms of, and to ensure the NHS delivers this, the Children and Young People's team has been developed within the National Medical Director, NHS England and Improvement. And it's fair to say that prior to, I think, about a year or 18 months ago, it was there was really just one or two people working on child health with some clinical input. And a lot of you will have heard Jackie Cornish speak before, who was our predecessors. And then in the autumn last year, I was appointed as National Specialty Advisor, and Simon Kenny, who some of you may also have heard speak before, is a paediatric surgeon from Alderhay, is the National Clinical Director, taking over from Jackie as well. And then over the last few months, we've built a team of a policy team to try and deliver on the children's chapter, basically, of the long-term plans. So like lots of things in, well, not just healthcare, but healthcare in particular, most plans that were in place in January and February this year changed out of all recollection with COVID outbreaks. So what I wanted to do next is just talk you through a little bit about what we've observed so far about the impact of COVID on children, and then talk you through about how we're reshaping some of the program of work to make sure that we lock in some of the innovation that we've seen through the pandemic, but also make sure that no one gets left behind. So I just want to start with a slide, and hopefully this is, again, not news to people, but what we've seen really is that COVID is, in children, COVID represents a very mild condition, and children only represent 1 or 2% of the cases. The vast majority of children who contract COVID-19 don't need to seek, well, often any healthcare at all, and very rarely require hospitalization. I think in those children that do require hospitalization, they tend to be children who have other comorbidities, and there's an overrepresentation of neurodisability and respiratory conditions within those children that are both admitted to hospital and those that go on to be admitted to intensive care. What I would say is, I know this is a talk about asthma today, is that asthma, we haven't fully been able to break down all the kind of coded data of admissions and PICU admissions over the last kind of 6 to 8 months. But they're talking to particularly the intensive care colleagues, we're not seeing asthmatic children in that group of respiratory patients that require hospitalization or intensive care support with COVID-19. What we are seeing is children that have impaired cough and more chronic lung disease, and often with an overlap of neurodisability. So generally speaking, I think we feel quite reassured that asthmatic children certainly are not overrepresented in the population of children that are being admitted to hospital. What this slide doesn't really talk about, and again is not related to asthma, but certainly a lot of primary care and hospital colleagues on the conference will have heard about this so-called the new syndrome, which I think is currently being called pediatric multi-system immune syndrome, temporarily related to COVID, or the name keeps changing around, but it's this sort of inflammatory condition that's Kawasaki-like in nature. What I would say is we're not seeing an overrepresentation of COVID in that group of children, and also that is still a relatively rare disease. We don't have exact numbers still, but I think we'd certainly be saying there are less than 100 cases of that, and most of those cases have been on the milder end of that condition as well. So that's something that I think is important for people to know about, but it doesn't really change the underlying message that in the vast majority of children, including those who have certainly moderate asthma, and not seriously affected by the disease. So I think actually what lots of paediatricians and teachers and other healthcare and education colleagues involved in looking after children have recognised pretty quickly that actually the risks to children didn't really stem from COVID-19 itself, but much more from the societal changes that accompanied the pandemic. And the most obvious of those are closing schools, but also the way that healthcare has been delivered has caused a lot of anxiety. And certainly at the beginning of the pandemic, there was a huge amount of anxiety. There were children who would have otherwise presented to their emergency department with sepsis, pneumonia, sickle cell crisis, a range of other conditions where the family were too scared to come to hospital. Actually, although there were isolated cases of that reported in the media, when you actually look at the data underlying that, there wasn't actually that much data to support those anxieties. And it does seem that most children continue to access healthcare fairly effectively throughout the pandemic, but there were obviously cases when that wasn't the case. So actually, as a national team, we had a range of things that we were trying to work on. The first thing was that when you're sitting in a big NHS planning meeting, thinking about how do you increase your critical care capacity by 4, 5, 6-fold over the space of a very short period of time, which we saw with lots of hospitals achieve, and then also with the Nightingale hospitals, the natural gaze tended to think, well, actually, we don't think children are very seriously affected. Why don't we use some paediatric intensive care capacity for adults? And obviously, it's really important that all services play their part in an emergency, but there was a real balance to be struck between saying, okay, yes, there is some capacity we could generate by delaying some elective procedures, but there are also a lot of time critical, either whether that's pediatric cardiac surgery, for example, or children who become unwell with almost any condition who need some pediatric intensive care capacity. So there was a lot of work done to try and strike a balance between protecting the capacity for those who need it, but also supporting adult colleagues where possible. And actually, I think when we look back over the last year, it's very reassuring that we actually didn't run out of paediatric intensive care capacity at any point. So a certain extent, I think that was successful. There'll be people who say that we probably cancelled too much elective activity, but that's probably a debate for elsewhere. I talked a little bit about delayed presentations as well. And then there was also something about it's not just about medical vulnerability, but there are lots of families who really rely on services, whether it's extra services, whether that's support through social care and children's services, or the support that the family get from school and school nurses and education as well. So there was a real anxiety about how we identify those children and try and make sure that the most vulnerable children continue to receive kind of universal services and support throughout the lockdown. And then really, this is something which again isn't used to anyone, but moving to these new virtual models of care to understand, how and when this really works. There are clearly lots of examples of where virtual consultations are very successful. It's more convenient for the family, sometimes more convenient for the clinician, and you can have a really high quality interaction. But there are also times when it doesn't work as well. And I think we need to be clear that it's not that Attend Anywhere is not a panacea for all the problems we have and all the waiting lists we have in outpatients as well. So really trying to support our colleagues to identify which patients could be best managed remotely. And then there's a piece of, then there's been quite a lot of work looking at the various data sources coming in and trying to communicate some of the evidence out. And I think actually, I talked earlier about the multi-system inflammatory disorder, that actually the first cases of it definitely weren't in the UK, but actually the NHS were the first health system in the world to actually be able to share enough data to confirm this was a new condition and publish on it as well. And Mike Levine from and his colleagues from Imperial College London have done the academic work on that. But I think it's a real tribute to actually what the NHS can do, which very few other health providers in the world can do in terms of looking across the whole country, looking at children who are suddenly ending up in intensive care and being able to pull together all the kind of laboratory and clinical information about them to identify a new condition. So this really just talks about some of the things as a program we're trying to do over the next year to support children and young people. And some of these were sort of projects that were already started, but we've had to slightly tweak, and others are new things that we started doing as well. So I think support, as I sort of touched on this already, really, but about bringing back elective services and ensuring we have critical care capacity, remains a real challenge. We'll perhaps talk about shielding later, but certainly the impact on children and young people and their families of having to isolate prior to elective surgery was very significant. And we've been able to do quite a lot of work with the Royal Colleges and PHE to try and actually minimise the burden of that for children and young people and their families. There's something about really working, as I said, about virtual by default, but also I suppose running alongside that, there's a lot of most people I think about virtual by default, certainly in hospitals, as sort of outpatient clinics and chronic disease management, whereas actually, particularly for our primary care, for colleagues in primary care and the 111 service, more and more families were choosing to use 111 to access emergency, or if not full emergency, certainly urgent advice about how to manage their child, ideally at home, because I think most families understand about not overburdening the NHS in terms of coming to A&E, but also have some anxiety about coming to A&E. So we've done quite a lot of work with 111 service, and one of the things that we're just starting to analyse now, but I think has been a real success, is that most people who phone 111 are initially spoken to by a non-clinician who takes them down an algorithm to try and identify what support the family need. And in the case of children, most of those children are called back by a clinician. That could be an advanced nurse or a GP. What we've done over the last few months is to deploy some paediatricians into that clinical workforce, so that if you have a child whose family are phoning up 111, and actually the GP or the advanced nurse is uncertain whether the child needs to immediately be attended, go to a hospital, to call an ambulance, they can actually call on a paediatrician who's immediately available to them as well. And actually, we think from the early data on that, that's actually been very effective, both in terms of the kind of safety of the service. We've seen as a reduction in the number of children that 111 are calling ambulances for, but actually also a lot of families feel very reassured to have actually had the opportunity to either speak to a paediatrician directly and through a video consultation, particularly out of hours, or know that their GP or advanced nurse has discussed their case to them as well. So I think that's part of how we really move to a more sort of 21st century approach to urgent care, rather than having waiting rooms filling up with children. And then there's, as I said, there's a piece of work really about identifying those particularly vulnerable children through healthcare and education, and then trying to make sure that health visitors and other key services are available to them. There's a bigger piece of work going on about data and informatics to really try and make sure that we understand both the impact, the direct and indirect impact of COVID-19 on children, and trying to shine a real light on the inequalities that may have been opened up by the COVID-19 pandemic. And as we have more data available, we'll hopefully be able to share some of that. So I think just moving forward, really, in terms of how we work as a national team, we work with the system. I mean, I think one of the things that COVID-19's taught lots of us, there's lots of things that we knew were wrong with the way we delivered healthcare over a number of years, but COVID-19's kind of forced us to change those. So, and the use of technology, virtual consultations, and a more integrated approach between primary, secondary care, community care, and education is really what's required. So we're really continuing to focus on supporting integrated care systems as they emerge to work better for children. And then there's a couple of, or there's a few very specific pieces of work that are ongoing. One is around transition, and I know this is important for asthmatic patients as well as for other children with long-term conditions, that there is, as children stop being adults at 16 or 18, depending exactly what condition you've got and where you are in the country, the transition to adult care can be very difficult, where a lot of adult services are not as well resourced as children's services as well. So thinking much more closely about that. I mean, obesity obviously has a significant overlap with asthma, but also so many chronic conditions across the whole life course as well. And there's a huge range of things that need to be done on obesity that range from areas of public health and policy that sort of are beyond the remit of NHS England, right through to how we manage the more severely obese children in specialist services as well. So there's a big piece of work going on with there as well. One of the plans is to develop a national asthma bundle, which is something that I know that you'll all be interested in, and I'll talk to in detail at the end. And then a piece of work on speech and language as well. And obviously none of this work is possible without a sort of joined up workforce strategy, which we're developing with Health Education England as well. I think probably this next slide just covers many of the things that we've talked before about driving integration, and I'm conscious that I want to allow plenty of time for questions. So I thought I might just instead focus on integration in this slide as well, because I do think this is really germane to the discussion that obviously happening about asthma as well. And what this slide tries to do, I suppose, is really show how complicated integration is, because I think depending where you sit in the system, you think about integration in different ways. And I think, to me, actually, asthma is the test case probably of all the long-term conditions for integration, because on the one hand, you could talk about integration being between primary care and secondary care, and access to sort of secondary care, either inpatient admissions for emergencies or clinic support for more complicated patients. Equally, there are people who sit in secondary care who actually think the problem with integration is actually the integration between the specialist difficult asthma clinics at tertiary hospitals and DGHs, and how that flows backwards and forwards. There are people who are very concerned about whether we've got the right emergency pathways, and particularly the pathways into PICU, whether the right children, whether we've got an integrated pathway across secondary care and intensive care at the tertiary units. And then actually, as everyone on this call knows, that actually your outcomes in asthma are far more determined by things far broader than availability of specialist services and pediatric intensive care. That actually, you know, a home environment that's free from smoke, air pollution, adherence to medication, making sure that school nurses know how to give asthma medications and that asthma medications are available in schools, are actually much more important as well. And actually, you know, if we're going to seriously transform the outcomes for children with asthma, we need to be tackling, as the NHS and as a society, we need to be tackling this whole thing. So this slide here is just a way that one of the ways that we've sort of chosen to think about all the people that we think are involved. And as I say, there's what's the current terminology is that we have horizontal integration, which is between the NHS, local authorities and education, and then vertical integration, which is between bits of the NHS essentially, so primary care, secondary care and specialist care as well. So just conscious of time, what I want to do now is just talk to you about the very, very early stages of where we are with thinking about what do we do about asthma as NHS England to try and drive the transformation that everyone recognises is required. What I would say is that the time frame at the top here is all provisional, so I wouldn't want you to get too focused on the time frame, but what I hope to do really more than that is just to explain a little bit about how we're thinking about how policy can translate into action to actually improve outcomes. And I think the experience that NHS England have had is that actually by developing the terminology as a bundle, or you could call it a policy, or you could call it a group of policies, or you could call it a group of guidelines, but essentially a collection of things that systems need to do to improve outcomes is really effective. And we've looked around, not just within paediatrics, but across the NHS to see where this has been most effective. And actually, some of you may know about the Saving Lives Care bundle in maternity care, which is specifically designed to reduce stillbirth rates. And I think there's some early evidence that that's working. But so actually what we've tried to look at is what did they do that was really effective? Because stillbirths are similar to, in some ways similar to asthma, that it's not just about having effective neonatal intensive care or effective labour wards. You know, that's a condition that has many components to it as well. And so the plan is for NHS England to develop in collaboration with wide group of stakeholders and experts is a asthma bundle. And that will have at the minute, but again, I would stress this is provisional and may change a little bit, probably 5 what we're calling elements that affect what we think are the core things that integrated care systems need to change or deliver to improve outcomes in childhood asthma. And so I think starting on the left-hand side of the slide at the bottom here, there is clearly something that we're calling prevention, which I know whether you can prevent asthma or not is a bit of a technicality in itself. But actually, I think what that bundle really is about having a healthy lung environment, a healthy environment for children to grow up in. So really making sure that we've got the smoking cessation right, that we've got GPs and health visitors all getting the message clearly, but also thinking about air pollution, what local authorities should be doing in terms of green walls around school playgrounds, green routes to school, and then also making sure that there's a real commitment, particularly in social housing, to make sure that housing is kind of suitable as well. And I think probably sitting in here, not mentioned on the slide as well, is there's also something about I guess health more generally. So in that, I would think about exercise, obesity, all as well.
Oh, sorry to interrupt you, Matthew. Could everyone make sure they're on mute, please? Somebody's not got their microphone muted.
Thanks, Oliver. Then again a piece of work that's really around early and accurate diagnosis, which I think still sits predominantly with primary care with really good support, and then some secondary and tertiary care involvement for the more complicated cases. There's then something about an element really about once you've got a diagnosis of asthma, really effective delivery of your preventative medication, and that's around self-care, the role of possible apps and things for monitoring asthma remotely, and then making sure that somehow that care plan is really well linked up with 111 primary care, secondary care, to make so that we know when we're assessing patients acutely how compliance has been. Then there's another similar element, which is this time related to actually, even with well-managed asthma, we're always going to have some exacerbations. So again, it's really about self-care 111, making sure that patients know how to access care when they need it and know when they need to go to hospital. And then I think there's a piece of work to be done just to sort of smooth out some of the bumps in the pathway, particularly between the ambulance services, secondary care, and very, very rarely intensive care. And then finally, we do recognise that there are a group of children with extremely severe asthma, which doing the basics right still isn't good enough. And these are the children that need to be looked after in the severe or complex asthma clinics, children's hospitals. And there's clearly a need to continue to support research and development and new therapy for the more complex cases. And just, I suppose, they're the underlying all of this plan to me, there are really two key themes. The first is about skills and training, that actually none of these elements work if families aren't being looked after by people that have had the skills and that have had the training and then the skills to deliver those elements effectively. So I think there are lots of examples of really good training and educational material available, but actually really trying to standardize that and saying, actually, if you're diagnosing a child with asthma in primary care, we think it's reasonable to expect that clinician has had a level of training. Likewise, if you're doing annual reviews, is the clinician doing the annual review? Have they had the right training as well? So there's something about really making sure that within each of these elements, there's a piece of training. And then finally, there's a really big piece of work to do around data as well, because actually we know an awful lot about asthma, and we know about when things go terribly wrong and children die. But actually, I think there are questions around, how much school children are missing because of their asthma, the variation in that across the country, just as an example, that we really don't know as well. And actually, as we start to develop the data tools to help us really understand that as well, that will also help us focus our attention where it's most needed, and support local clinicians to support families. So I think probably I will leave it there, just to say, sorry, that's been a bit of a canter through what's quite a lot of work, and actually hopefully some people have got time for some questions and discussion.
Thanks for that. Thanks for that, Matthew. Really appreciate you coming along today. So we've got a few questions. Apologies if I don't get to all of the questions. I think just for the sake of time, we may not have an opportunity to ask all of them. One from Mark Levy wanted to know, it seems that there were excess deaths in April as reported by the Office of National Statistics. Does Matthew have any info on excess childhood asthma deaths this year? And does he have any data on children who had asthma attacks in the community but didn't access care? Do we know if any of that's available at the moment?
So what I don't have is detailed data on asthma attacks in the community. I think what we did see was a reduction in hospitalization across the board for conditions that are, and at the minute we're only able to break that down as respiratory, so which we'd expect some of those to asthma and some of those not to be asthma. So I think that from the point of view of children having asthma attacks in the community, my feeling is that children probably weren't, because they weren't, or there wasn't an increase because we weren't seeing them in hospital. And actually talking to paediatricians across the country, I think we've all noticed there that during the lockdown there were less children wheezing in hospital, and we know that, and I suppose we know that viral illnesses are one of the triggers for asthma, so that would fit together. I think when it comes to death, Mark, it's a much more complicated picture. We do have the National Child Mortality Database as well, which I think, but actually what I would say is I'm not aware of any childhood asthma deaths during the lockdown period. I can't tell you that definitely doesn't mean there are any, because we don't have all the data every day, and sometimes it's not clear what the cause of death was overall, but it's not been flagged to us that there's been any deaths, and it's not been flagged to us by our PICU colleagues or our secondary care colleagues that there's been an increase in severe or life-threatening asthma in hospital. So I feel reasonably reassured, but as I say, I don't have the data to absolutely answer that, I'm afraid, Mark.
Okay, thanks, Matthew. And I'm sure I know Mark was beginning to perhaps look at this, and I think would, if anything does flag up, well, obviously we'll be sharing that. So thank you for that. Let me just get back onto my device, take some more questions. A really good point from Kath Evans. Have the national team recognised the amazing impact of CNSs in enhancing care and integration to improve experience and outcomes? Their work across communities, schools and hospital care is significant.
Kath, the answer is definitely yes. And I think just making sure that we really learn from the best and try and spread that nationally is going to be absolutely critical to delivering the changes that we need.
Yeah, fantastic, thank you. Richard Shavas mentioned, just going back to the work earlier on, there was says there's no mention of poverty and antenatal issues in your slide deck earlier. Is that an oversight, or what's the
so yeah, that
where
is,
do you pull that in?
I think where that all pulls into is a healthy environment for children, along with the elements, along with air pollution, and as well. And I think there are other people that are very concerned about, antenatal smoking and things as well. But I think it all fits into there. And I mean, we absolutely recognise the link between poverty and poor outcomes. And actually, as I say, I think it's through the data that you can actually shine a light on that and really make sure the resources are going to where they're most needed. So I think, yeah, that's a really well-made point that isn't clear on those slides. And as I say, I just want to kind of stress again, they are an embryonic set of ideas that will be consulted on widely. They're not the final thing. So when you see the final version of this document in the future, those bundles will have probably had their name changed and things move around. I just wanted to give you a kind of flavour of the way we're thinking about dividing up the work. That's certainly not a definitive list of all that's required, and we recognise that.
Okay. So a quick question from me, Matthew. Forgive me if it seems a little leading. There's fantastic work being done at a regional level. As an example, London. How are you ensuring that you're, as a national team, are working with the people who are already doing the work locally?
So, I mean, I think today is part of that, Oliver. I think that, we recognise there's loads of really good work. I agree the work in London's excellent. The Beat Asthma work in the northeast of England is also fabulous. And by not naming people, please don't be offended. There's just so much good work going on around the country as well. So we are really going around and talking to all the regions and local systems that are doing good work already, trying to work out which elements of their work are scalable. And I think which elements of what they're trying to do, it makes sense to do well once nationally. And I think, you and I, Oliver, talked about competencies and training in asthma within that was a few months ago as well. And I actually think it wouldn't make sense for London to have a whole framework for training practice nurses, paediatricians, A&E doctors, and then in the northeast there to be a different one. Whereas the actual delivery is very local as well. So really we are in listening mode. And if there are people on the call that are aware of good work they think should feed into this, we'd urge you to be in touch with us. And as I say, we are keen to listen. So I don't think there's a definitive list of everyone who's doing good work in asthma that we could just work our way down. But as I say, we are doing our best to meet the local experts and hear what's going on, and make sure that where possible we can just incorporate and scale some of that work, because what we don't want to do is just invent something from scratch when there's so much going on already.
Fantastic. Thanks, Matthew. Arvind Shah, you have your hand up.
Hi, thank you very much. It's fantastic work, and I think integration is the key for primary, secondary, and tertiary care to reduce the hospital deaths and all admissions and all that. One of the things which we see, there are recurrent attenders to A&E, and some of the work we did, if the anxiety score is high, parents will take the child to A&E. Yeah. We used to have that carer of liaison A&E health visitors. They are no more existent now. And there's a big gap there. So we need to have guidance about how, I know some people are running A&E clinics and things, but any way to tie that up, because you see those are recurrently coming to A&E with anxiety, and they form the bulk of A&E work. Thank you.
Yeah, I mean, I think that's a really good point. And I think I touched on school nurses, but health visitors are an equally important part of the equation for the younger children as well. And you're right to say that the focus of health visiting seems to have changed over time. And certainly when I was a junior doctor, that was a totally, that we relied very heavily on that service, which doesn't exist anymore. So, really think that's very much in our thoughts as well, but also kind of recognising that health visiting is a little bit more complicated because it's commissioned by Public Health England, not NHS England. There is politics involved, and we have to be careful not to overstep our mark. But it's a really well made point, Arvind, and that we're thinking about very actively.
Can I come follow on that? I think here there's an opportunity to join up with public health, even with smoking cessation and all that. There's a lot of work done in America, in New York, where there's no asthma deaths and things. It was because of integration with public health and all resources going in one place. So I think there's an opportunity to pull that together.
I think that I completely agree, Arvind, and I think just to reassure colleagues that we are, by me saying things are commissioned by Public Health England, that doesn't mean we're not working with Public Health England. We meet weekly with the senior team at Public Health England who work on child health as well, to pull all our work streams together. And obviously things are slightly changing at Public Health England at the moment, but we are absolutely committed to that. And I think that there will be sort of explicit recommendations about how health visitors and continue to work with particularly primary and secondary care as well. So yeah, no, I think you're absolutely right. If we're going to change this, this is not a NHS England only issue. This is a public health issue and a far wider society issue that we need to try and tackle, or to make things better.
Thank you.
And I think, and also just to flag, Arvind, there is an awful lot of work happening across the different ICS footprints across London with regards paediatric asthma networks. So certainly if you're at the North Mid, would invite you to become part of the North Central London Paediatric Asthma Network. All of those issues that you're raising about, what's happening about integration and, where does social care fit in, all of that stuff is being looked at, it's recognised, and obviously you're welcome to, if you're not, welcome to be involved in that. Richard Shavas, last question from Richard.
Sorry, I put my hand down because you asked my question. I just wanted to raise that point about poverty being sort of central in the bundle, because absolutely. I think without managing that, we're not going to help out elsewhere.
Fantastic. So thank you all. Apologies if I didn't get to your question, just for the interest of time. But I'd like to say thank you to Matthew. Thanks for coming along, Matthew. Really appreciate it. It's great to have you along and kind of talking to us about what's going on at a national level. So much appreciated. I will be in touch soon because we need to get that competencies chat going again.
We do. Thank you very much, everyone, for your time. As I say, if there are questions or things you want to raise, do feel free to get in touch either in the chat or email me, and we can put you in touch with the right people.
Superb. Thanks, Matthew.
Thanks.
Right. So we'll move on to next agenda point. And just before we move on, can I just ask everyone to make sure their cameras are switched off? We don't need to see each other. That's all fine. We'll just leave that with the speaker. I think, Rebecca Lee, your camera seems to still be on, but anyone else, I can see that one. But if anyone else has got their camera on, if you wouldn't mind just switching it off, that's helpful. Thank you. So we move on to our next agenda point. So this is talking about the useful piece of work that's just being done around same day emergency services. This is a work with 111, how 111 can support children with minor asthma symptoms. And I'd like to welcome John Moreras, and I see Giles is on here as well. I don't know if Giles is presenting as well, but I'll hand over to John. John, are you doing your own slides, or are we doing it for you?
I think it's going to be a trio of people. So Giles is going to talk first, giving an overview and remit of the project, and then hopefully I think we've got Roland on the call as well, who is a paediatric registrar who's done the vast majority of the work here, putting it all together. And then actually it's been quite a big collaborative piece of work with lots of people from the London Asthma Leadership Group, in particular Mark Levi. So there'll be a few of us, I think, that then can field any questions that other people have with regards to the pathway. So I'll hand over to Giles.
Thanks, John. So I have got some screens to share, so hopefully this will work in a second. So can I just check if everybody can see that on their screens?
Yeah, we can see that. Thanks,
Oh,
Giles.
good.
Brilliant. Okay, so I've been asked to set the context of where this pathway has come from and what we were asked to do. And then, as John said, Roland will take you through the actual pathway design as it's been signed off, and John, Mark, and other people who are involved on who I know are on the call, like Richard and Stephen, can help field questions. We were essentially were working on paediatric asthma as one of the 12 London SDEC pathways prior to the onset of COVID. And it was one of the things that was chosen as one of the issues to try and help in terms of meeting the national mandate to try and improve same-day emergency care. The impact of COVID meant that we were asked to do something slightly different, because initially it was thought that some of the shielding paediatricians who were seconded into 111 might be able to help and manage some of these children remotely and avoid them having to come to the emergency department in the first place. That turned out to probably not be workable, mainly because we didn't know how long we were going to have the shielding paediatricians in place. And so a decision was taken that rather than build the system to be reliant on shielding paediatricians, we've upskilled the clinical call handlers of 111 globally to be able to manage asthma that doesn't necessarily require transfer to a secondary care site to manage. So historically, the 111 pathways have taken a very cautious approach to paediatric asthma exacerbations. And effectively, if you rang up 111 and said, my child has paediatric asthma, the default option was you would end up being asked to attend an emergency department, even if you really didn't need to, in terms of your asthma severity symptoms. So what we were asked to do was to pull together a clinical guideline that would support clinical call handlers in managing mild exacerbations of asthma, so that these children could be managed remotely and avoid them having to attend secondary care altogether. In terms of the things that are novel around this, there's been the introduction of a 4-hour callback feature, which 111 had the capacity to do but hadn't actually started doing. And so that's been integrated in this pathway. So what happens is you ring 111 as a parent with a child with asthma. You're seen by a non-clinical call handler, first of all, who does a rapid set of screening questions to make sure you don't need immediate transfer to the emergency department. Assuming that you do not meet immediate criteria for transfer, you're then passed to a clinical call handler who goes through the guideline, which Roland will talk you through in a moment. And they then, if they assess you as being mild, they give advice and guidance to the parent. They can e-prescribe by dispensing prescriptions to be collected from the pharmacy closest to the family home. And they then do a 4-hour callback to make sure that everything has happened as it was meant to happen. The pathway has now been signed off by everybody that you can see on the screen, but most importantly, it's the London Asthma Leadership and Innovation Group have signed it off, and all the 111 providers in London have signed it, as have the Pan-London Clinical Leaders Group, which includes the Regional Medical Director for NHS E&I. The plan is hopefully to go live he says next week. We haven't quite got the final go live date. The slight delays, we're just waiting for some education to go alongside this to support the clinicians who aren't as familiar with this in how to use the pathway, which John and Mark can talk about if need be. And the expectation is that it will hopefully mean that fewer children who have mild exacerbations will be sent to our emergency departments, which I can assure you, having done 2 shifts in the last 48 hours, are already feeling the strain of respiratory presentations and the challenge of managing those in the days of COVID. Just as a final highlight, in terms of where next, assuming this works and it will be evaluated by 111 as part of this process, then the 2 prongs next in terms of paediatric asthma ESDEC for London. One is we're going to see whether, if this works well for mild cases, could we use it for moderate cases? There's a big question mark over that, but that's the next plan for this pathway. And then the second piece of work, which I have to start once this one is finally up and running, is looking to see how we can standardize early discharge from all the units across the capital, because there's currently massive variation in when you are allowed to go home from a asthma exacerbation, with some units asking you to get to 4 hours twice on your suboptimal and some kicking you out at 3 hours. So we're going to try and do a piece of work looking at what the pan-London picture is and whether we can produce some guidance around standardization, possibly using things like hospital to home services to support early discharge safely into the community. I'm going to hand over to Roland at that point, and then what I would suggest is if you pause your questions until the end of that, so that Roland has a chance to go through the pathway, and then John, Mark, or whoever's on the call can pick up those questions as need be.
Hi, everybody. Thank you very much, Giles. I think Giles has kind of said most of the important bits. Firstly, I'm Roland. I'm Roland Benstead. I'm one of the general paediatricians. I'm not an asthma specialist. I'm not a respiratory grid. I was brought on originally as a shielding doctor when we thought it was going to go that direction, but things changed slightly. But I continue to be involved in the design of the former. So just talking you through it, as you can see, this is for children over the age of 5 who have a diagnosis of asthma. Like Giles says, they speak to the triage guys, and then they hand you over to the GPs and the rest of the team. At that point, they'll do just an ABC assessment, so to make sure there's been no deterioration between the triaging and the assessment. Obviously, with asthma, we know it can deteriorate very quickly, so it's vital that we have that in place. This is novel in terms of the use of video assessment as well by 111. So if it's just mild asthma, then we can get away with just being telephone review, but anything more than that, and if possible whenever we can, we would like to use video assessment. This has all been designed with the 111 and the GPs, so we kind of know what their capability is of remote assessment. We've been through it with them, which has been really helpful. So just an ABC evaluation. The guys on the end of the telephone are very used to speaking to the parents and asking them to kind of describe what they can see, asking them to count the respiratory rates, doing capillary refill times, things like this. And then with the extra added video assessment, we'll be able to look at that as well. So seeing for accessory muscles, seeing for nasal flaring, etc. If possible, we want to be doing peak respiratory flows, looking at their predicted and the best, and then taking it from there. So hopefully we'll be able to get a good assessment of that child from telephone, but hopefully from video. Obviously with video there is some people won't have access to that, so that's a worry, but we can always do telephone. So moving on to the next slide, if Giles can hear me. I don't know if you can.
Yeah, there's a hang time, but it should refresh in a second.
Cool. So the next slide shows the next part of the pathway, which is just a short history. So some prompts going through the past medical history, the history of presenting complaint, looking at how much salbutamol they've been on, On the actual pathway, there is a third page which has a much more detailed prompt. So if you have somebody at the end of the telephone who isn't as used to pediatric asthma, it's got a very detailed pediatric asthma history, which is useful for the less kind of experienced guys. From that, so from the ABC, from the history, we can then look at the exclusion criteria, those that should be coming straight to ED for assessment. So in the big red box, this is ones that they just need to be ringing up the local EDs and sending them in, or getting LAS to go around and pick them up. So at the moment, we're just doing mild asthma, and maybe in the future we'll be doing moderate. We'll see. So it was a trial period at the moment. So if the treatment's not working, it's ineffective. If they're needing more than 4 hourly salbutamol or more than 10 puffs of salbutamol, then they need to be coming.
Yeah, so these two are giving it.
Oh, I think somebody's unmuted themselves. So patients on oral maintenance steroid therapy, patients with difficult to treat or severe asthma, patients on high dose SABA or SABA not being effective, previous IV therapy, recent discharge from hospital or interactions with GP or 111, which should be on the system, PICU admissions, other comorbidities, poor compliance, significant parental anxiety, safeguarding concerns, communication issues, anything which is flagging worry, then they should be coming straight to ED, and they're not a candidate for staying at home for review. So if you don't fit into the exclusion criteria, if you meet the mild asthma criteria, then the call handler will be flagging. They'll be doing a risk assessment, whether or not you need some salbutamol there and then giving the parents safety netting, and then putting the child in line for a call back in 4 hours. So as you can see, the rest of that box, you move over to the 4 hour callback. Giles, if you could spin on to the next one.
Yeah, it'll just take a second to refresh.
All right. So those in the mild category, those not meeting the exclusion criteria, are put into a callback, which is the first time, to my knowledge, that 111 have been doing that. So they can be reassessed at 4 hours, going back to the ABC, seeing whether or not they need further treatment. If they don't, then they can be pushed on to a 24-hour, 48-hour review in primary care or with a nurse specialist. At that point, we can be thinking about referral on if needed. We're also being able to put in place e-prescribing, so if they need a course of steroids or if they need a further supply of salbutamol, which will be gleaned from the history at that point. So that's the main bits of that, I think. The last part of the pro forma is basically just the BTS guidelines put into a kind of nice format. Like we say, this may be scaled up to moderate asthma, but it's also there for people who may deteriorate during this time. So there's guidance there for the call handler, looking at the parameters and whether or not they need to be getting an ambulance straight to A&E for these patients. That's the kind of main part. It's quite simple, hopefully, and it's easy to kind of talk through and work through. I think Giles said this is going live hopefully soon, but at the moment John is looking into creating a training package, so for the call handlers to learn more about asthma, learn about this protocol safely in the community.
So just to add a few things if I can. So I think Mark Levy has been doing the asthma education package, because I've trying to fit as many life events as I can into this week, moving house, etc. So big thank you has to go out to Mark for producing an excellent training package for that. And the second point to say is that if you look at it, we've taken quite a cautious approach, I think, in doing this because it's new and there is an element of risk involved with it. And we really kind of want to prove the concept and prove that it works. And if it is working and we can prove that it's safe, we have plans to look at ED attendances following these enhanced asthma calls and looking to see that we aren't having children having to present to ED in emergency. Then perhaps we can relax some of the exclusion criteria that we've included currently. But that's why, if you're wondering why we have so many exclusion criteria, that's why we've done it.
Fantastic. Thanks all so much for that. It's a really interesting piece of work. I think we'll all agree, something really really useful. So there are a few questions that have come in on the chat, so I'm just going to pick them up for you. One from Chin: how long do we think this triage conversation takes to do with the practitioner who is familiar with the scenario versus someone who is new?
So I think the initial 111 screening call probably may only take a few minutes, but then you're being passed on to a second call handler, such as a GP, nurse, or an experienced paramedic who should have time to do a more enhanced asthma review. So I guess it would be the same amount of time as we would do in ED, so somewhere between 15 to 20 minutes, I would have thought. And hopefully it will be the same person who then does the callback, but not necessarily, depending on how shift patterns work.
Okay. Thanks for that. So pretty comprehensive, and it's just accepted that it just takes a long time to do it properly, which is great.
That is the hope, that they're not going to be time pressured. I think you can't, if we're really trying to avoid an ED attendance, then we have to expect that they are going to go into some detail in order to assess what the risks are, that it is safe for that patient to be at home, and what immediate management or needs to be put in place to cover them over until they get seen face to face, if they need to be seen face to face.
Yeah. Okay. And thanks, John. Okay. So one from Sakeshi: were you able to prescribe medication from the system to community pharmacy using e-prescribing?
So that is, I think, is the hope. The precise details in terms of how we're going to do that, I'm not sure. Maybe Giles can chip in here, but we are looking at if a child needs a course of oral steroids, that we can get that to them in one way or another. And we've also been talking about the timeline of it, whether they need to, if they're ringing out of hours, whether we can get it to them out of hours, or actually can it wait till the next morning when they can pick it up from their local pharmacy.
So just to add, 111 already has a well-established prescribing pathway for various medications. So this is not a new system, it's just applying it to asthma.
Okay, fantastic. Thank you. Chin had a comment about where does the community or hospital CNS come into this? They may be well placed to inform decision-making process in, e.g., anxious patients.
Yeah, that's a really good point, is which I think maybe something for us to look for in the second phase, which is how do you actually link in with your localized asthma team, either in the hospital, community, or CNSs. And I think in order to do that, we're going to need to build up a map of London, if this is just being piloted in London for the time being, so that the GP call handlers know how to redirect. But I don't think we've got to that stage yet.
Okay, fantastic. There's a question from Arvind around pulse oximeter use, that more families with children have pulse oximeters. Should there be something about that into the pathway about SATs monitoring at home?
This is a point also that Mark Levy has made, and I thought we had put something in there. So not all families will have it, but for those who do have it, then yes, we can use it. I think we all recognise that your SATs dropping is an important indicator that you're having a severe asthma attack. So technically, those children shouldn't actually come into this pathway, but they may deteriorate either in between the 4 hours of the callback, or actually during the call. So I think we have included something on it.
Okay, thanks, John. So a couple of hands up, Mark Levy, and then Richard Shavas after that. Oh, Mark, is your microphone working? Yeah, can't hear you, Mark, I'm afraid. I'll go to Richard, and then Mark, if you put your question into the chat, we'll pick it up from there. Richard?
Yeah, so it's just a comment coming back to the clinical nurse specialists and the in-hospital asthma teams and their input into this. I think, from my understanding, the ESTEC pathways are looking at pre-hospital and also within hospital how we direct people away from the emergency departments who don't need to be seen there. And so I guess when we're looking at the sort of mild to moderate people, there may be pathways that hospitals, if they've got the facilities, can develop that and then linking in with the 111 service. But I think it's work in progress.
Okay, fantastic. Thank you. Just see if there are any other questions. Oh yeah, so there was a question about how will this impact primary care? Do we expect this to have an impact on primary care?
So not hugely. I wouldn't have a thought in terms of every individual practice. I guess these are children who are having some sort of asthma exacerbation. So whether they came to ED or whether they're being dealt with through this new call handler system, they will all still need a 48-hour review. So, and I think these children still then need to be plugged into their local GP so that they can get that 48-hour review, because if they're given steroids, then they need to have a longer course, and also to have a more in-depth and long-term view of their asthma control. I think Giles has come on. He's may have something to add.
Yeah, just to say this was picked up in many of the discussions when this was going through the sign-off process, and exactly what John says, this is not new activity for primary care doctors. This is the standard that's been advised by the BTS for many years, that after an exacerbation there should be a 48-hour primary care review. So it's hopefully meaning that they're not coming to hospital for us to ask them to do that. It's been done without the child ever needing to come to hospital in the first place.
Yeah, thanks, Giles. And there are kind of other work with them direct, those direct bookable appointments in primary care by 111. So there's already the kind of ability to do something about that. Chin, you had your hand up. Chin, are you there? You're still muted, I think, Chin, if you're trying to speak.
I always think that we should set up a gift aid type system, and anyone who speaks while muted has to donate 50p to the local charity.
Yeah, I think Chin, we haven't got you, but your hand is up. Okay, maybe that's not happening. No, we can't hear you, Chin. Put it in the chat there. You just don't seem to unmute, I'm afraid.
Maybe Chin could put his question into the chat box, and maybe someone can read it out if there's a problem with his audio.
Yeah, do you want to message quickly, Chin? We'll just have a quick look at it.
I'll put my email into the comments after the talk, so if anyone wants to ask me any questions afterwards, then they can be free to email me.
Yeah, okay, thanks very much for that. Thanks for that, John. So and the chat will be sort of ongoing in the chat function, so perhaps if Chin does that, and if it's something you need to pick up offline, if you're not immediately able just to answer his comment as it's raised. So yeah, fantastic piece of work again, just a really interesting way of how we can support children with mild asthma exacerbations in new ways that don't necessarily involve attendances at ED or through primary care, and plenty of opportunity there as well, it sounds like, for the future, not just with moderate, but then those links in with the wider services as well, and that information sharing also. Yeah, thank you all for coming along, Roland, John, and Giles. Thanks for coming along to talk about that. We will move on to the next element of our agenda, which I will just bring up just so we get the order right. So now this is basically an opportunity to have updates from various SDPs of various different areas across London and the work that they have been doing since last year on children's asthma. So a great opportunity to hear about this fantastic work. The presentations are all going to be so it's going to be 15 minutes per area with a 5 minutes opportunity to put some questions to them. I know it doesn't feel like much considering how much work there is to be to talk about, so apologies for that. For those of you who are presenting, if you're getting close to the end of your 15 minutes and you seem to still have quite a few slides left, I'm going to butt in and let you know, just because you know, it's we've got a lot to get through. So apologies, I don't mean to be rude, but I will give you a bit of a warning if it looks like you're not going to get through your deck. So without further ado, we will start with South East London. Let me see who's speaking. We've got Amy Westphal, Rebecca Calamchi, Nina Somerville, and Richard Isles, who will be talking for South East London. So whichever of you wants to kick off, I will hand over to you.
Thank you. Are you guys controlling the slides for us?
Yes, we can do. So just say next, and Chris Chris has got the slide deck up.
Brilliant, thank you. So hi everyone, my name's Amy and Becky's with us. We're the two children's community asthma nurses in Lewisham. So next slide, please. Next slide. Yeah, so we're a small team. There's just the two of us. We were commissioned by Lewisham CCG and started as a pilot over a year ago. A 1 year pilot commenced in December 2017. This has been recently fully commissioned and extended, and our service has now been running live clinics for 2 years. Next slide, please. And the next one, please. Thank you. Yeah, so we do 48-hour reviews, and we do education and support appointments and assessments for children with asthma. We do also see children with episodes of viral-induced wheeze that have been seen in A&E, but we would only accept them if they've been had 3 or more attendances in 6 months, and that's normally from Lewisham A&E. Our children must have a registered Lewisham GP for us to accept them. And we also see non-compliant asthmatics, and we get referrals from GPs and A&E for those children as well. We can offer home visits for some of those children that we're really struggling with compliance, and they keep reattending. And it's also a good opportunity for us to go into the home and see if there's anything environmentally that we think might be triggering their asthma. We don't keep our patients on our caseload for a long period of time. We normally, the 48-hour reviews, unless there's been any changes made, we may discharge them after 1 appointment. The education support ones, if there's a compliance issue, we are able to keep them on, and we are finding more and more children that we're keeping on for longer and catching up with them. But as there's only 2 of us, that's something that we're going to work towards expanding, hopefully. Next slide, please. So just a quick run through of what we've been able to do through the COVID period. So initially we had to stop all of our face-to-face appointments, but because, as I said earlier, we don't have a massive caseload of patients, because the backlog wasn't massive, we didn't have to cancel any appointments, so we just moved them over to telephone call reviews. And then any ones that we were concerned about or felt we wanted to follow up, we kept them on the caseload, and we were able to, once we moved on to virtual appointments, we were able to follow them up virtually so we could actually see them. And we have now started to do face-to-face clinics. So we've kept them on and brought them in if we need to. As the same with everyone, we had very few referrals for 48-hour reviews. However, we did tend to get more referrals for education and support from GPs, which was really nice. And we've worked out that that is something that is achievable to do over the phone. So yeah, Attend Anywhere has been really good. There's been a few teething problems, but our parents seem to like it, and we're definitely moving towards integrating that into our reviews more and more into the future. Especially children that we would see coming to clinic didn't have the correct spacer or inhaler device, and it just means that we can catch up with them once they've had the correct one prescribed by the GP, rather than bringing them back into clinic. We can actually do that virtually, and parents have been really, really grateful for that. It was also a great opportunity for us to update all of our resources, and we've been offering out teaching for GPs, students and schools. We've created an activity book which was just sort of updating at the moment, just something that we will make available for children and their families whilst they're in clinic with us. And then an update of our 48-hour review information leaflet that's handed out to patients in ED. The big piece of work that we've done over the summer is actually complete an audit of the service, which Becky is going to talk you through. Next slide, please.
Thank you. So I'll quickly run you through the audit that we did. So we wanted to audit our service since we commenced 2 years ago, and COVID gave us the opportunity to do that. So we looked at the incidence of hospital reattendance post-consultation with the community asthma nurses versus paediatric A&Es, and that was in 2 to 16-year-olds diagnosed with asthma. And I think our total, off the top of my head, was 101 patients that fitted the criteria. That wasn't the total referrals we had, but they were the ones that fitted our criteria. And we used what we benchmarked our service against when we started to audit the service. So they were 4 main points that Ask About Asthma highlights and the NRAD report. So that every patient has a asthma action plan, the inhaler technique is assessed for each patient contact. We reviewed oral steroids in the past 12 months, and then the 4th thing was looking at our reattendance rates. The next slide, please. So we found that 98% of our patients in the period, which was February 2019 to, August 2019 to February 2020. So in that time period, we found that 98% of our patients received a personalised asthma action plan. For one of those patients, there wasn't any documentation, so we had to accept that or take that as the patient didn't receive one. For the other patient, the parents had misunderstood discharge information at discharge. And on the discharge sheet they were given, it said that the supply of the Clinell inhaler was for 14 days, and parents thought that they only had to take the Clinell inhaler for 14 days. So we advise that that's not normal protocol. Just double check with the consultant that had discharged, and we confirmed that parents had misunderstood the information given, but that specific patient had follow-up with the acute respiratory nurse at UHL, and we were sure that they would be given an asthma action plan when they were seen in clinic. So that would have been accounted for. Next slide, please. So the next thing we looked at was inhaler technique, as I said, from August to February, and we found that 100% of the patients we had reviewed received inhaler technique assessment. Next slide, please. Then we reviewed oral steroid use in the past 12 months. And unfortunately, we found that 15% of patients that we'd reviewed didn't have documentation that their oral steroid use had been reviewed. We may have asked it, but for the purpose of the audit, it wasn't written down, so we had to say that 15 of those patients hadn't received a review. Next slide, please. And then we audited our return results, which is essentially what our service had been commissioned for, was to reduce unnecessary attendance to A&E. So out of the 101 patients, we found that 6 patients, so 6%, returned within 30 days. And we looked at the reasons for that. So 2 of the patients we attended prior to being seen by us, so, before they were followed up by us, they had reattended themselves. 4 of those patients we had reviewed, and because of their acuity, asked them to return to A&E. So we had followed them up, but they hadn't recovered and weren't appropriate to manage in the community. And then we just noted that there were no more than 2 patients per month that reattended during that time that we audited. Next slide, please. So,
sorry to butt in. I think you may need to pick the pace up a little bit. I see how many slides you guys have got left.
Okay, no worries. Thank you. So our conclusions were that every patient received inhaler technique. Only 1 patient didn't receive an asthma action plan. Our reattendance rate was small. And we found that the reason that the majority of patients didn't receive steroid use review in 12 months were the patients that had a 40-hour review with us. And on the performer we use for our system that we document, there wasn't a box to write that information. So we have now added that to our performer to ensure that it is documented. Next slide, please. So off the back of that audit, we did a second audit to review the incidence of reattendance to A&E prior to the asthma nurses starting in post. And we measured it against the same benchmarks that we did for our own service, which you can see there. So the asthma action plan, inhaler technique review, steroid review, and then their reattendance rate. So that was for if they'd had an asthma exacerbation and all their care given in A&E, we wanted to find out what their reattendance rate was like. Next slide, please. So this is just quickly to run through. So we found, blue is yes and red is no on the key here. So the audit period again was from August 2016 to February 2017. So that's the period, same period we audited, but prior to us starting, and that was 174 patients. So we found that 164 of those patients did not receive an asthma action plan, and that's from looking through the notes on the system that ED document on. So we had to do it in the same way as ours. So if there's no documentation, then we assume that they haven't received that care. So like I say, 164 patients didn't receive an asthma action plan. Inhaler technique wasn't checked for 160. Previous steroid use wasn't reviewed in the past 12 months for 165 of those patients. And out in 30 days, 141 of those patients did reattend pediatric A&E. Next slide, please. And this slide just is a comparison between the two. So A&E remains in the red and yellow. So yes for A&E is blue, no for A&E is red. And then our results are yes in the light blue and no in the light yellow. So it's essentially a mirror image of each other on those results. Next slide, please. So our conclusion was that our team have markedly reduced the number of attendances to hospital for asthma exacerbations and dramatically reduced reattendance rates post 30 days consultation with us for asthma exacerbation. Next slide, please. And this was just very quickly what we've been doing this week for Ask About Asthma. So we arranged a virtual presentation for all GP staff within Lewisham, so that's GPs and practice nurses. The offer was also extended to our acute trusts, so QE and Lewisham, and school nurses as well, and our community-based Kaleidoscope. We completed that yesterday and just highlighted the main aims of the campaign and how people can help out with that, especially on week 38. And we are noticing a spike here already. We had a Q&A following the presentation, and unfortunately we haven't been able to have a stall in the hospital because of COVID, which is completely understandable. But we are doing drop-in events and walk-arounds in the hospital where COVID allows us. And very last thing, I don't know if anyone can see this, we have had T-shirts made as well to highlight. Next slide. And that's it from us.
Hi, good morning. So my name is Sarah Allmark and I am from the service called Children Young People's Health Partnership. And my colleague Nina actually created this slide. We were asked just for a couple of minutes just to talk about what just the next borough along from Lewisham, Southwark and Lambeth have been doing sort of during the COVID outbreak. So before started this year, we are a service of children's nurses that are a project that's working at the moment to see how we can sort of enhance the primary care provision across Southwark and Lambeth. So we as a service actually run clinics for asthma, constipation and eczema, and Nina is our asthma nurse specialist and myself and 4 others are the primary care nurses within that team. And at the start of this year we had locations, we were doing clinics across Southwark and Lambeth, trying to see families in areas that were really helpful to them, so children's centres and health centres, and had a quite large caseload really, and we're very busy. We're trying to educate and support our mild to moderate asthma caseload to try and prevent them from needing to go to kind of increase up to a kind of tertiary hospital level support. And then, as we all know, COVID happened, and within a week our service was actually asked to suspend so that our nursing team could be redeployed to help support the coronavirus response. And as a team, we were asked to move into the Evelina at home team, so still within our kind of community colleagues, but needed to obviously help them with the service provision there. So basically within a few days we had to stop our service completely and run a very skeletal service of basically just checking in with our asthma families that we had already accepted to do telephone calls. Within our redeployment, we were given sort of 2 hours a day for one nurse to try and focus on our CHIP caseload rather than the hospital at home caseload, and just had to do that ad hocly and try to do things over the phone. And that lasted for a couple of months, but sort of during that time we were able to work really closely with our hospital at home colleagues, which was a great opportunity sort of within itself. And now we got back up and running properly from August, which was great, and we've basically completely redesigned the service. We now are doing the majority of our clinics, so 5 virtual clinics a week, using the Attend Anywhere platform, and then we do have capacity to use some face-to-face provision when we feel like it's needed, but a completely different service to really what we were offering earlier this year. And from that there's been some challenges that we've all had to face, and these are just some of the things that we kind of are particularly aware of at the moment. The things that we've talked about already, the impact it's happening on children and families as schools, the experience of school is so different now for our families. Big high risk and safeguarding of trying to get make sure that our vulnerable families are getting the best care possible. We were pre-COVID doing quite a lot of home assessments, which we all know is hugely beneficial, and at the moment we've completely stopped those, just to the safety of being able to provide those. For us as staff, there was a big backlog of patients, of initial assessments of families that we had accepted pre-COVID but not actually been able to see, and then all of the children that were referred to us during that time that we needed to try and catch up on, trying to do that over the phone and virtually is, as I'm sure we're all finding, quite tiring, and we have all sort of struggled with that, and you know, the technical difficulties that come from virtual appointments, we're still sort of overcoming that, and just a few things that we've learned along the way and are constantly learning. There's been increased phone calls of parental anxiety. Just yesterday at about 4 o'clock, we had 2 families of children that had gone to 2 separate schools. There had been a notification from those schools that there was a positive coronavirus test, and those parents were now calling us to let us know and to ask whether their children, because of their asthma diagnosis, were they more at risk, what did they need to do. And that of course takes a lot of liaison with all the different care provisions with the schools to make sure we're all singing off the same hymn sheet. We know that lots of families were struggling to get hold of their medications during that time. They were wanting to get hold and have a kind of stockpile of their inhalers, and as a result there was a national shortage, and that caused a concern that we were trying to manage with families over the phone, making sure that if they were given a different inhaler device, they knew how to use it, they knew if they needed to adapt to their dosage at all, which was really important. But we also had a great opportunity, like I say, to learn in terms of working collaboratively with our hospital at home and community children nursing colleagues. We were able to help support them in the initial trial of doing administration of omalizumab injections during in those kind of home clinic appointments, and we've been able to carry that on, which is a great opportunity for us to keep increasing within that, and we're just kind of aiming onwards and upwards to keep trying to help our asthma families across the boroughs. Thanks very much.
Superb. Thank you so much. I know it's a real real whistle stop through some fantastic work. Richard, is there any kind of conscious of the timing, apologies for the tightness of this, is there anything you want to add?
Just a plug for our network meeting on the 6th of October, and further details will be sent out as soon as possible. Okay. Fantastic.
Thanks, Richard. And I suppose just very briefly, is there the kind of priorities for SEL? What are the things that you're going to, kind of wider?
I think we're working on we're working on the network approach, trying to get everybody kind of compliant, or at least signed up to a network approach. I think some of the innovation is around increased use of smart inhalers and smart diagnostics. Some of the other innovation is actually we're working quite closely with the digital group and starting to bring in the Red Book. And we've had recent discussions about putting asthma into the Red Book for South East London, which hopefully will be one of the ways that we can actually tie everything together. So quite a bit happening. It's nice to see the excellent work from the other units, but we're trying to bring that really closer together.
Fantastic. Thank you all so much. So that's Southeast. So we'll move on to Southwest. And as I said, just a reminder to all of our presenters, our 15 minutes goes really fast. So yeah, just bear that in mind as you work through your deck. So for Southwest, we have Richard Chavas and I think Joe Lawson as well, but certainly starting with Richard Chavas.
Hi, you can. It's me, Richard Chavas from St George's Hospital, one of the respiratory paediatricians, and then hopefully one of the Croydon Community Asthma Nursing team will be online to discuss their work. I don't know if that will be Joe, but we'll get to that. So next slide, please. So the first thing is just about the network as a whole. I think I'd like to apologise that there's been relatively slow or little progress with the Southwest London network over the COVID period. We had set up some regional education meetings in last year and the year before, which was a start of trying to get a clinical group together, but we're keen to sort of have a regionalised system and to engage with South West London CCGs. The STP lead for children was also in maternity, and I think has been redeployed back to maternity, so there doesn't seem to be very much in the way of leadership coming from the CCG at the present time, but I've been having meetings with our CEO and other people to see if we can get an overarching children's board set up. And then as a clinical unit, we will be planning some further virtual network meetings in the not too distant future. So next slide, please. So asthma activity during the COVID period, again, as mentioned earlier, we've published the data from St George's Hospital, and the graph here shows our asthma activity over the past 3 years, with the gold line at the bottom, the presentations to St George's Hospital over the COVID period, with the marked cut-off or drop at the start of lockdown. The grey bar is the asthma attendances for last year, which clearly shows the week 38 spike, and clearly we're about to enter that phase now, and so it'd be interesting to see what happens this year. We have had 2 or maybe 3 admissions to PICU already this week, so the tide is turning. Whether that reduction in admissions was relating to all the various things that were discussed earlier on, viruses, pollution, adherence and stress, my hunch is predominantly on the spread of viruses. I think within South West London, looking at the pollution data for Battersea and Wandsworth, there wasn't a distinct change in PM10 or even NO2 over that period of time. So clearly looking at as to what happens over the next few weeks and months. Next slide, please. Just looking at our local children's asthma board, so the Wandsworth and Merton Children's Asthma Board, we've got a number of projects that we're running pre and post COVID. We've talked before about our school emergency asthma bag programme, which were distributed at the tail end of 2018, early 2019, and we've reviewed the use of those, and there is a publication coming out in Archives, short publication just documenting some of that. We have noted that the bags were used used in anger by 30% of the schools and on 81 occasions over the sort of 6 to 9 month period that we were surveying. So clearly there's a need, and probably there's a need for further education to make sure that children have their own asthma inhalers and spaces and asthma plans in schools. And our initial school bags are coming to the end of their expiry dates, and we've got agreement now to reissue those bags, and we'll continue to do that on an annual basis. The next exciting project that we're doing is actually to extend that to an anaphylaxis bag for each school as well, and there's hopefully going to be imminent distribution of those to the local schools over the next few weeks. There's a lot of hard work that's gone into that, and potentially will have bigger implications for prescribing adrenaline devices to children and young people in the area after that. One of our other key work streams has been how we maximise the 48-hour reviews, and we've done audits around that, but our plan has been for some time to try and get all of those appointments booked with their GP practice by the emergency department or through the wards prior to discharge. And although it seems like the most straightforward thing that should be technically possible, there seem to be an inordinate number of barriers getting in the way, but we're slowly getting into the right direction, the right direction. And the fourth project that we were looking at and running was diagnostic hubs to try and facilitate getting objective measures, as Richard Iles discussed earlier on, sort of akin to the NICE guidelines available for all children over 5 from primary care. And these are looking at having some diagnostic hubs within the region where they could have a one-off history taken, objective measures, and hopefully then passed back to the GP. Again, that was due to go online in June, but has been COVIDed, And now with the COVID restrictions on pulmonary function testing, it looks like that's going to have to wait a little bit longer. But interestingly, there are similar sort of plans, I suppose, for adult diagnostic hubs and lung function sort of facilities to be available for primary care, and hopefully we can tie in with those work streams as well. Next slide, please. Both of these things have been mentioned before, so I won't go through them in any more detail, but obviously I've been involved both with the SDEC pathway, but I think, as I intimated before, the SDEC pathway is not just 111, but will also be what the hospital end of the system is able to offer. And I think there's a hope that we don't need to have all of these children in the emergency department, but could be seen by the asthma team or the paediatric team in a different area. I don't think at St George's we have one of those at the present time, but we're looking at an urgent treatment facility that might provide that. So more work waiting in the future. And again, through my links with LALIG, we've sort of contributed to and looked at the difficult asthma plan that Louise Fleming will publish later on, but that referral pathway. Next slide, please. And then just looking at really what we've done through the St George's Asthma Clinic and our work here. So unfortunately, all of our clinics have had to be telephonic throughout the pandemic. St George's has been unable to offer widespread video clinics due to IT issues through the pandemic phase. The only clinic that we've had that has been able to use that to date has been our dysfunctional breathing clinic that was presented at the King's meeting last week. Who've had the ability to use Attend Anywhere, and that's our joint clinic with psychology and physiotherapy. We have been able to do a few face-to-face appointments for those children with unstable problems or diagnostic issues, but it's been relatively limited and very limited pulmonary function through the bulk of the pandemic. What we have seen, obviously, is through the telephone calls, I think, improved attendance. We don't have or haven't seen as many DNAs because we're able to track people down, and we'll continue to ring until we speak to them. And as per my comments earlier, I think we found that actually most patients have been stable, and most have said they've been the best they've ever been. So clearly the impact of social distancing and being at home and not having the stresses of schools seems to offer some benefit. As for the redesign of our services, we are going to have limited face-to-face capacity, and I think we're going to be somewhere in the 35 to 40% pre-COVID levels. And we'll be offering a one-in, one-out system, so that we'll have, patients will come in straight into a consulting room, will be seen by the medical team, the nursing team, and where possible physiology, and we have to get the appropriate filtration systems in place. And then the rest of our clinics will be telephonic, and hopefully more video coming on stream as the computer systems get better. Our physiology service, and I notice a question coming up there, we have restarted some pulmonary function testing, predominantly spirometry and bronchodilator reversibility and FeNO, but in reduced numbers with fallow periods in between tests. And we're also looking at the alternatives to support that, so the use of home spirometry devices and impulse oscillometry. And just looking back at one of the comments from the previous talk, again, with our clinic has offered for quite some time now. Our asthma nursing team see all of the children who get admitted to the ward for education asthma action plans, and they see a significant proportion of those who just present to the emergency department, either managed primarily in the emergency department or the PAU. And we have a hit off that if you attend twice within a year or have 2 courses of oral corticosteroids, you're brought to clinic, and we do a fuller assessment at that time. So I think that's all I was going to present. So on to the, I don't know if Joe or someone from the Croydon team is online.
Yeah. Hopefully you can hear me.
Go for it.
Okay, so I'm Jo from the Croydon asthma team. We've just got a couple of slides, so it should be quite quick. Just to say that we usually do home visits for all the children that we are referred, but during this time we used Attend Anywhere video consultations. They proved to be a great success and enabled us to keep delivering our service. So we were able to use our airway models, show them what asthma action plan looked like, and assess inhaler technique. And we found this a lot more valuable than using a telephone review. So now going forward, we'll be offering all new referrals a video consultation and saving our home visits for more complex patients that we need to see the home environment or those with safeguarding concerns. And this hopefully will mean that we can crack through our referrals quite quickly. We have had a big influx, like a lot of people this week. We've had 25 referrals in 2 days. So we're hoping that using the video consultations, especially for the younger ones with wheeze, will help us to make some headway with this. Next slide, please. And then just to touch very briefly on an audit that my colleague Jackie carried out, we used the slightly quieter time during the pandemic to look at 100 children, just over, that we have put on our high risk register. So these are children with complex asthma and comorbidities, safeguarding concerns, etc. During this time, they were given additional interventions such as regular telephone follow-up. We were also attending joint consultant clinics while these were running. So we wanted to look at what had been happening with these children after we'd seen them. So we were reviewing their symptom control and adherence to treatment and current medication. And it was a big piece of work to do, to go painstakingly through every child's notes, really to look at how many inhalers they were ordering, whether they'd represented to hospital, how many courses of oral steroids they'd had, and this was pre and post intervention. The results were really pleasing. We got some really great repeat ACT scores, and I think now that we can monitor GP prescription records, adherence tends to improve, because I feel like, we feel that parents, once they know they're being monitored, are more likely to order their preventer inhalers for their child. So great piece of work to be able to do in that time. I don't think we would have had the opportunity otherwise, but it has shown us that we need to sort of develop our service, hopefully moving towards an MDT clinic for our asthma patients in Croydon. And that's it. Thank you.
Fantastic. Some really fabulous work. Thank you for getting through it like that. So yeah, we have had some questions come in. Stephen Goldring's got one in the chat. Any views on using peak flow in emergency departments and the practicalities of that? Perhaps that would be for Richard.
I'm not sure that there's a huge change pre or post COVID. I think there are people who believe strongly in peak flow, and there are people who believe less strongly in it. But it's a tool that's available to us, and where spirometry is less easily available because it's probably more aerosol generating, I suppose it's one of those modalities that's available to us.
Okay, thanks, Richard, and I suppose this would be watch this space as we all think about it. Let me have a look. Richard Arles has his hand up, so let's go to Richard.
Just, can you hear me? Yeah. Just very briefly to say that peak flows in the emergency department are probably not very helpful, but peak flows as an assessment of long-term condition probably is. So peak flows are helpful at home, looking at stability, but not necessarily as a predictor of admission in an A&E department.
Okay, that's thanks, Richard. Deborah Waddell.
Yeah.
Hi, thank you. Thanks, Richard. I'm Debbie from Asthma UK and BLF Partnership. I just had a question. It might be a fairly simplistic question, really, an operational one regarding the school bags. I noticed that within the school bag you had the disposable coffee cup spacer. It's something that we're quite interested in at the moment because we're getting a lot of calls from schools who are really worried about the volumatic being in there and using of the volumatic, and concerns about the MDI, and lots of questions about can I use the disposable coffee cup spacer. How have you found children adapt to that if they do need to use the emergency spacer, understanding that they have to use their own is always predominantly the first choice, but how do you find they adapt if they're used to using a tidal breathing method with their volumatic or aero chamber? How do they cope with transferring over in an emergency setting when they need to use it with a single breath hold?
So I think, to my knowledge, you can still use the tidal breathing technique, and there's plenty of work that's looked at.
Okay.
You know, anything is that makes a spacer is better than nothing. So lemonade bottles and things like that can be modified. So I wouldn't be too precious around that. I think you know, where schools have probably bought themselves an emergency volumatic or similar, all brands count, spacer, obviously they are supposed to be single patient use and shouldn't be just washed and used on a different date.
Yeah.
So I think you have to have, if for these emergency kits, you have to have a disposable set of spacers. When in the survey, and we had responses from 70% of the schools that we've given the bags to, there were I think 5 or 6 schools that said that they had had a slight difficulty with the coffee cup ones, just putting it all together. It's not rocket science, so I'm not entirely sure why that was the case, but I think it's the only solution.
Thank you very much.
Yeah, thank you. And so the last question, how are things going with the asthma friendly schools program in Merton and Wandsworth?
So our Joe Lawson has been working on that, and I think has got some further meetings coming up, and I think it's slowly taking shape.
Fabulous. Thank you all from Southwest. Great to hear that the sort of work that's being done, and that kind of continued continued efforts, particularly Richard, you driving that with regards to the children's network in the area. So we'll move on to our next presenters. This will be North East London, and we have, let me see, Rita Araujo and Linda Hassel from North East. Rita, I'm sorry if I messed up your pronunciation. I try so hard every time I try and pronounce your name.
Apologies, that was so much better, again. Oliver. That was brilliant.
Fantastic. Over to you guys.
Good morning, everyone. So I'm going to start. Hello, I'm Linda Hassel. I'm the Divisional Director of Nursing for BHRUT, and Rita and I are partners in crime working across North East London, chairing the Children and Young People's Asthma Network. So our presentation is very much headlines. It's just some headlines to give you a flavour of all the work that our teams have been doing across North East London over the last year. Can I have the next slide, please? So initially, just to focus on our workforce, because we've had a huge change in our workforce, mainly based around our wonderful CNSs. So we founded our network in 2017, and we had 2 CNSs, and this year, 2020, we have 9. So not bad going, really, that we've more than quadrupled the number of very important CNSs who really are steering the care together within the multidisciplinary teams and the multi-agencies for children with asthma. So these are all have different roles. They work very differently. Some are community-based, some are hospital-based, some work between the two, and some of their work involves reviewing children in inpatient wards and ED. Obviously, with everyone, that major changes due to COVID, but Certainly, we did have some children admitted, and the ones that came into BHRUT into Queen's were still reviewed on a face-to-face basis by the CNSs and those who went into ED. Otherwise, all the clinics moved to virtual with telephone hotlines and continuing virtual now, unless, particularly with some of the diagnostic tests needed or the tertiary clinics, they are moving to face-to-face when needed. So I think that's pretty much the same as everyone else. Their role in connecting partners across the system has been considerable. School nurses, primary care teams with the practice nurse and GPs, and lots of teaching there. And some of the events you will have seen possibly advertised across northeast London, and particularly using social media and Twitter. They also frequently meet as a group. So they meet as a group of northeast London nurses every 6 weeks. And they've set up the Pan London Children's Asthma Nursing Forum, which some others of you on the call on the programme today might be members of. These meetings are quarterly, and they were so oversubscribed to start with. I think everyone had to be quite firm about that this was a London-wide network only. Now with everything moving virtually, I'm sure they can probably open the door slightly, and there were a lot of other nurses that wanted to come from outside London. So that could be the makings of perhaps a national conglomeration, I was going to say, of CNSs. So something really that's growing there, really important, support base for them, sharing good practice. So that's moving in a very powerful direction. Next slide, please. So in relation to pathways and guidelines, we have a lot of work to do. We had quite a lot of work to do just even in BHR, being in the first year of setting up our new network. Fairly standard things like information leaflets, all different sorts of things all over the place, making sure that there's some uniformity, whether it's in the same organisation. We have organisations that have different sites to make sure that all the sites have the same leaflets and information that are ratified, evidence-based, all saying the same thing, and no diversity away from that. So that took quite a lot of work and has been quite successful. Writing care plans for the children that are actually admitted, and making sure that we've got the right pro formas in place. Big focus on safeguarding. Was not brought policies being put into place for GP practices and primary care outlets, and being reviewed and audited. And even within the acute trusts that was not brought policies in place, we reviewed ours, we did an audit, and we found it just wasn't as clear as we wanted it to be. So we're actually rewriting that. That's in BHRUT. We've also written some really big, meaty operational policies that actually knit together the primary, secondary, tertiary interface, what the thresholds are for children moving between them, and the pathways being put in line with best practice. One of them that's been done has taken nearly a year to get right, but we have taken that time to get it right so that it really works and it's fit for purpose. So a lot of time has been put into developing these documents. In terms of transition, I think everyone is probably aware this has been quite rightly receiving a lot of focus this year, with an initiative run by NHSEI to make sure that all organisations actually look at this in the right way and that the right standards are in place. So that is very much involved with the asthma work, and in fact some of these big operational policies. We've got a number of locality or network incentive schemes in place. Certainly the one for BHR was fairly mountainous last year, the one that Dan Devitt led. And I think he's written a blog for this Ask About Asthma week on that. Discharge planning and EDSs. We found some real challenges here that others may share in relation to the timing of the EDSs, making sure they're actually released, they go out with the child and there's no delay. The coding of the whole episode and the accuracy of what's actually written, so the content. And we had some very helpful feedback from GPs in relation to there could be some improvements to the accuracy and the content of these EDSs, which would be very helpful to GP colleagues. So we've been working on that. In relation to the challenges of the 48-hour reviews and actually making sure that they are achieved, there are a number of different models across North East London of these being done, of how they're managed, of what constitutes the review, of who actually does the review. And I know we've had some examples of that from the other parts of London, other colleagues during this event. One snapshot audit of the BHR team did was the model they were using was that they would review the child, review the EDS, and that the parent would be given the number of the GP surgery to actually make the appointment. And on the snapshot audit, they found that 38% of parents had an appointment and 44% hadn't. So it's just interesting, just with snapshots, looking at what is working, what isn't working, what are the different models and how we're going to improve it. So that was just very quick example there. Moving on to schools, huge amount of support for school health teams for children returning to school this autumn, particularly after all the challenges of COVID. And a real focus on webinars and education sessions being provided remotely across North East London.
Next slide, please.
Oh, yes, thank you.
Next slide. Yeah.
So these have been provided to primary, secondary and special schools. Those are the main categories. And a number of them have been held right across North East London by the various CNSs and teams. This has helped then to build relationships, and there's been a real increase in phone calls and queries from school colleagues to CNSs that simply didn't happen in the past. And I'm sure that's been a very positive result of actually now being able to put a name to a face and getting to know people. Many of our schools are working towards asthma-friendly status across the patch, and that obviously work's going to be picked up and continue. On one particular example we just wanted to headline was group consultation to children, families and staff that has actually identified a number of high-risk children that weren't recognised by either the children themselves, the families or the school staff. I think, Rita, you just wanted to give a little bit more information to that.
Yes, so just a quick highlight about that. I think there's real, this was kind of a national first. I know HLP has more information, we've shared that. But effectively, I think it's really important that we consider, the importance and the impact of group consultation. Because it truly gives a real good opportunity to kind of pick up your high-risk children that they're not necessarily known, or the majority of them that were identified as having high risk of having an asthma attack, they actually hadn't been to A&E, they've not had an admission. So there's a lot of potential there, I would say, for us to continue this kind of really tight-knit approach with trying to kind of identify all our wheezers and asthmatics in schools, having a solid program. In this case, we've done that jointly with family and staff and health professionals, but being really clear about how we identify these children earlier rather than waiting for them to pitch up an A&E. Actually, I think there's a great kind of opportunity here of really identifying these children way earlier. And I think group consultations are definitely a way forward.
And then making sure, obviously, with the management plans in place.
So I'm going to talk a little bit about the air quality. So a lot of you will know now that we've been working quite closely in terms of this theme, and I'm really happy to let you all know that actually we've managed to co-produce materials on air quality. I noted a question earlier about as well smoking cessation and the importance of actually bridging the two. These materials been co-produced. There's actually a session that's already been shared in this Ask About Asthma event, so please log into that if you're interested. So it's a really quick kind of training session. It's CDP certified, and there's actually, we've managed to develop really practical materials that anyone across the system, and I can't emphasize that enough. So it's not just health professionals, although health professionals were highly involved in this, as well as obviously families and children and young people themselves, that you can actually share that and use that in kind of a consultation, or we're even exploring that with voluntary sector about how we kind of promote this really important conversation and bridging of the asthma with the air quality. I'm really happy to announce and let you know that all the materials have actually been adapted nationally. So we used, obviously, the imaging that we used was more kind of local based, but it's now been adapted nationally. And if there's a contact there specifically, if you want more information about this, and again, please tune into the session that we've hosted for you as part of the Ask About Asthma event. Next slide, please. So I'm really, really proud because we've achieved so much, and these are just literally a few nuggets of across the system, so of what we've achieved. And I can't emphasize enough, obviously, the brilliant work that's been done by everyone. And these are just kind of high or outcomes or impact that we've, tangible impact, I guess, that we can share with you. So obviously a lot of the impact has been noted in kind of the acute admissions that we've had. Obviously the savings, we tend not to talk too much about money and just focus obviously a bit on children and people and the outcomes, but equally the reason we went from having 2 nurses to 9 is because we've proven that actually it's cost effective, it's efficient, we're improving lives and we're saving money. So that's kind of like the golden nugget, as I've been told before. Really happy to share that one of the boroughs, we actually have 70% of children actually having their annual review in primary care. I think that's brilliant. And there's been, really great work in terms of notifying and identifying, children that actually had a nebulizer at home, and the importance of actually noting the system about this and everybody being aware. There's a lot going on in terms of integration across secondary and primary care. The review meetings with tertiary leads as well as secondary care. So how do we bridge those? So kind of, obviously this so easily said but so difficult to achieve, but we're really trying hard to kind of get to this seamless kind of integration across the system. And we have a brilliant example again from another borough of people being trained, and this notion of asthma champions across the system, and really great videos. I know some of you have seen them across the system beyond North East London, to kind of clarify change of the approach. Next slide, please. So this is a video, and I'm hoping that we can put this on now. So this is a video. Obviously we couldn't bring children and people into today, but we thought we'd really share kind of a video that truly reflects the fantastic work and the importance of actually having an asthma nurse. And I'm hoping that actually, you all feel inspired, and it is really hard to do what we're trying to do here as a whole system across London. So
I'm 12 years old. Hello, my name is Carly Ashley Drad, and I'm 11, and I've got asthma and allergies. If I have an asthma attack, it feels like your throat is like closing up, and it's really hard to get air through it, and you just can't breathe. It's really horrible. My mum helps me when I'm having an asthma attack by making sure I'm taking all the right medication every day. When I'm at school and I'm having an asthma attack, my teachers get my asthma pump for me and my inhaler, and make sure I'm taking the correct amount of puffs. My friends help me with my asthma by always making sure that if we go out, I have my asthma pump with me. The good thing about having Tori is that she helps me with my asthma. Having an asthma nurse is good because she makes sure I get all my right medication. She talks me through my asthma plan. She comes into my school and helps me to try and make things better for me. Before I came to clinic, my asthma was bad because I got wheezy. I wasn't able to do PE or go out with my friends as much. Now I take all of my treatments. My chest don't feel as tight, I can breathe more, and I'm able to do more things with my friends. Pollution affects my asthma because it makes me cough, makes me wheeze. I have difficulty in breathing and have to close the windows. If I had 3 wishes to help children with asthma, mine would be that they realise that they're the same as others, even though they have asthma. My second is that they just realise life's not that tough. And my third is that they just enjoy that they're different than other people. If I had 3 wishes for the children with asthma, I I'd wish that they had a good asthma nurse, their asthma was controlled, and they had all the right medication.
Thank you for that. So I hope that
Christine Wilson, and I'm 12 years.
I hope that inspired you all, because I'm sure that this is kind of the reflection of all the children and people we're kind of impacting across London, and I can't emphasize enough how appreciative I am for everyone, especially obviously the people I work with across North East London, to do that kind of work and really kind of, I couldn't have put it in better words than having children and people actually reflecting the amazing work that's going on. So to finalize really is just next steps really. So obviously, as everyone else, we're adapting. We're constantly adapting our offer due to COVID. We've been having kind of issues, and I'm not sure other areas, I haven't heard it from other areas, but we have having issues around kind of, just the practical stuff of getting a lung function, obviously the virtual consultations that have been mentioned. Now we're really trying hard at getting a data dashboards across North East London, so we get more effective benchmarking. I know others across London have done that, so it's great, the sharing. We're implementing policies and pathways, so we're really trying to focus on the 48-hour review, and I'm really thankful for these kind of events, because last year we had the brilliant example of Islington, and we're now taking that forward and seeing how we adapt in terms of across the system, and how do we pick up and actually implement that. So some of you will know that we've been nominated for an LGC award. Hopefully we'll know the results of that in October, and we're due to also present a number of conferences. I would just like to say as well that I know that Linda wanted to mention something about community base for asthma CNSs. That's something that we're also working really hard on. Linda, do you want to come in?
Just very quickly, we've had real challenges in finding community-based clinic rooms for our teams going across the tri-boroughs. So although this hasn't been a problem, obviously, during COVID with everything virtual, it's something that just might be helpful to share that we're still having problems with a year on. So that is a potential challenge that we have got to sort out over the next few months.
Yeah, and just a plug in, if you want to know more about the LGC award and other more detailed kind of, because we did try to do this as concise as possible and leave some time as well for questions. I'd just like to invite you to kind of access the podcast that we've was really exciting and interesting to do with Oliver and Tori, and also Tori's written a really great blog as well, so invite you to kind of join those as well. So I think if there are any questions, we're happy to answer, and yeah, thank you everyone for listening.
Yeah, fantastic. Thank you both. Really wonderful to hear all that ongoing work and some great examples, I think, that we can all take away and utilize in our own areas. So I'll pose a couple of quick questions that just came from the chat. Rosemary had asked, is there a standard care plan template for school-aged children?
I think we've got
Linda.
Laura and Tori on the line. You might be best placed. Yeah. I suspect there are different ones certainly across North East London. But if either of you are able to reply to that, I think Laura's been replying to some of the other queries. Is there another one, Oliver, while we wait for them to? I'm sure. Yeah,
sure. So Grace Ollie asked, are the asthma specialist nurses completing care plans for the school-aged children for school-aged children to give to schools?
So I think the asthma CNSs are involved in this if they know the child. Yes. Otherwise, I think the GP does it. That's a reply I had from Laura. I don't know if Tori has any different view, but that's certainly the approach that she's told me.
I can come in as Tori. Are you on the line, or because Tori's been doing all this really great school work? If she is, that would be great to hear from her. But if not, I can answer. Tori, no.
Hello, can you hear me?
Oh yeah, there you are.
So we have been doing things slightly different in different areas, but we're all using the standard asthma plans from Asthma UK and Monkey Wellbeing. and we are all providing our patients those plans, advocating GPs using the same plans as well. But I know at Newham have done a new work around with schools and are looking at the standard Pacific plan to make it a bit easier if children and families haven't been given a plan by a medical professional. And we all will be trying to take that forward within our areas. So that is something we're just currently working on.
Great. Okay, fantastic. Thank you so much, all of you, for the presentation and the ongoing great work. I know there's been some comments in the chat about people wanting to reach out and get contacts. Thanks, Linda, for putting some of those details in. So yeah, again, if you do want to contact any of the speakers about the work that they're doing, please do drop that into the chat, and contact details can be swapped. So moving on to North Central now. That's my patch, but I'm not going to do any of the speaking. I might just chip in, but I'm leaving all of the hard work up to Sam Rostam. So Sam, if you're there, do you want to jump on and take us through the work in North Central, please?
Yes, hi everybody. Thank you, Oliver. So lovely to be here, and thank you so much to HLP and contributors. All that we've heard so far, I've been taking copious notes and learning lots already, so thank you. And what acts to follow from the last three updates from across the London system. So I will try my best. So next slide, please. And the following one, I'm hoping this is the right pack. Yeah, oh sorry, previous slide, thank you. I've got it in a slightly different order. So thank you. So last year we were presenting at the live Ask About Asthma conference without face masks and in real life. And I just guess reflecting on kind of pre-COVID and post-COVID work in this presentation. So we'd been outlining how in NCL we developed a whole system plan for asthma, recognising the importance of working across the partnership to support children and young people and their families with asthma more effectively. In North Central London, we're fortunate in that we've got a wide range of partners involved in our work across health, public health, environmental health, social care, early help, sports and leisure colleagues, pharmacy, schools, air quality teams and families themselves. And I guess further developing that system-wide NCL asthma network that we have in NCL has really facilitated this approach and enabled partners to engage and be part of the conversations about asthma, its impact for our population, and some of the solutions that we need to develop together. Next slide, please. So some of you may have seen this before. This is the outputs really from some of that work across our system to deliver some a consensus really around the outcomes that we want for our children and young people. So you'll see there are 5 strategic outcomes and a range of objectives that sit underneath there, which we've designed, agreed and committed to work together as a system. And you'll see there as well the alignment with the London Vision, thinking about air quality, access to leisure and activity there. And our NCL strategic plan was then designed around these outcomes and then worked locally to frame these within local plans and aligned with local priorities and population need. And I guess all at this conference will recognise that there are nuances across each of our boroughs and our populations, and that needs to be taken into account as part of that strategic approach. So understanding what needs to be done right across the piece and where you need modification and tailoring for our local boroughs. Alongside this, we developed a dashboard. You'll see the mock-up on the bottom left, and that has enabled us to have the oversight required really to monitor progress. It's really tiny on there, but we've included a whole range of system indicators, so not just thinking about A&E admissions and attends, but also thinking about missed school days, air quality, wanting to have a good understanding of our kind of pockets of deprivation across our borough. So really trying to pull all that data together to inform the solutions that we develop for our children and young people. And alongside that, we also commissioned a significant baseline analysis. I call it a bit of a state of the nation for NCL. For asthma, so that we as a partnership were really clear about where we were at with our asthma care, some of the challenges and the opportunities, and the critical path really to get us to where we want to be for our children and young people. I suppose the crucial bit to mention on this in this work is that we took this this strategic plan and a full report to each of the health and wellbeing boards and local borough partnerships across North Central London, and this was really a key enabler to gain that mandate really at the most senior level. You know, thinking about leaders of councils, chief execs from trusts and council, directors of public health, Health Watch, a range of key stakeholders to ensure that we had that mandate to kind of push forward locally. And that staff understood that they had permission, I guess, from their organisations to be able to support us across the network in delivering on that work. Next slide, please. And then my comedy slide there, you'll see. So things were going really well until around March, and then there was a little issue that seemed to transform all our lives really overnight, and our network meetings were paused while we all responded, as I'm sure many of you did, to the pandemic. But of course, part of this work rightly included a continued focus for our asthmatic population, including understanding the new challenges as well as the ongoing challenges that were brought to bear in 2020. Next slide, please. And part of this really was hearing from our families during lockdown. So felt that it was really important to engage in conversations with young people and families to understand what they were worried about and some of the barriers to accessing care and their experiences to help us really and inform our work for children and young people across NCL. So you'll see there, and I'm sure many of these are shared across London and nationally, worries about infection prevention controls on our sites, concern about being wrongly directed to services during the crisis, some thoughts about how they were accessing information and advice and what format worked best for them. WhatsApp groups, certainly a feature, receiving information from schools really valued. Also heard, you know, some of the things that were good about the care offer, so looking to build on those, and things that parents or young people felt needed to be improved. So for us, anecdotally, that's around sort of follow-up, and also some of the things that were really important to them as parents. And I've got, I think, in the middle of this pack, something that I certainly listened to and heard from one of our parents. So as a parent with a child with asthma, it's important that I normalise the condition and ensure that she's not daunted by any symptoms that she may have, so that she's able to take her medication without fear that she's different. And this was really helpful, I think, in just ensuring that we remain alive to the experiences of families and young people during this time, which has been challenging, worrying, anxiety-provoking, all of those things, even for us as clinicians and professionals across London and beyond, but certainly for our families. And then if we move to the next slide, please. And absolutely, I'm sure many will agree, a smooth sea never made for a skilled sailor. And I don't know about you, but sometimes I find I do my best work under pressure, and it's certainly been highly pressurised across the last few months. And with thanks, I guess, to fantastic colleagues in NCL that I'm lucky enough to work with, describing some of the work here. So our clinicians and others, like many of you in the other presentations, have continued to deliver incredible work despite the challenges, and have continued to innovate across the last few months. And just picking on some examples here, and would like to say that there are blogs and some podcasts that some of our clinicians and professionals have done that our HLP are hosting and I think putting live on their website. So I won't steal thunder, hopefully, from the detail of these. And if you can access those for more information, that'd be great. So, so adaptation of practice, we've heard in some of the other presentations here, has been vital, really, to be agile and flexible in the face of this challenge. And some great examples in NCL, particularly from our asthma nurses, where sort of moving to home visits, telephone appointments, and other kind of virtual ways of supporting our children and young people with really good outcomes and certainly significant reduction in DNA rates. And also our school nurses that have ensured that they've been reviewing all the asthma patients during lockdown, which I think has certainly supported that safety netting, given we've all recognised the risk that that the lockdown has presented for all our children, certainly those most vulnerable, thinking about you know, far less eyes on our families, really, through, you know, reduction of school closures, and other kind of safety netting, I guess, in the community where we can pick up and support our children and families. Development of community hubs in NCL as well, so that's enabled the continuation of outpatient appointments and expedited hospital discharge following admission across this period of time. And part of that, it would include children with asthma, and that's been really, really valued. Use of technology for consultations, thinking about the work of the Whittington video consultations has been fantastic. Our community pharmacy group has also just released a survey. I think it's closing soon or has closed, seeking views from patients and families about using technology for consultations. So it'd be really interesting to hear those findings. Work around extended asthma reviews, and also we've heard about the 48-hour review work that's been fantastic, led by some of our NCL clinicians at the Whittington. Continued work on the with schools and the rollout of asthma-friendly schools, which is still a key priority in NCL. All our boroughs have signed up for this work, which has been fantastic. And during the pandemic, our lead, Karen, who's written a podcast, done a podcast, I think, which is online and hosted, has continued to support directly pupils at school that are known to her, making contact with those and their families to ensure that they're followed up and continue to remain well, as have some of our other kind of education and health support teams. Also the air quality work, so a key feature of our network are our air quality colleagues, really engaged in our asthma agenda, which is fantastic. The anti-idling project, jointly led by Camden and City of London Corporation and supported by the Mayor of London, delivering education workshops to our schools, which has been really, really good take up and forms part of our strategic approach, really, to asthma in NCL. And then continued delivery of our local plans. So underneath that strategic NCL plan, we've got local plans for each of our boroughs, which again ensure that we've got that kind of consistency and kind of strategic approach when we're signed up to delivering those outcomes. But actually that may look, the method of doing that may look or need to look differently in each of the boroughs, depending on the relationships there, the resources, the needs and nuances of those populations. And that's been fantastic. And I suppose one of the examples of local plan delivery in action is can be seen in Camden. So they just had their local asthma network meeting, and really using a kind of a data-driven approach to focus on their most vulnerable, at-risk children, young people, thinking about kind of schools, and socioeconomic backgrounds, areas of deprivation, etc., and using that data-driven insight to provide some real sort of targeted support to those children and young people. And I suppose the other thing that isn't on here that needs to be said is the work around the asthma registry in North Central London, delivered by Cerner, which is due to go live imminently in North Central London, and that will provide us with a solution to the management of asthma care, particularly for primary care colleagues. So really excited for that to land imminently. On to the next slide, please. Thank you. And I suppose just reflecting on the learning from across the period and the key themes for us in NCL, which I'm sure are reflected across some of the other areas in London. Certainly the power of partnerships for us have been absolutely critical to our asthma work and a number of other pieces of our children and young people work. So having that strong partnership developed to support the asthma agenda has been absolutely critical, and far easier to have coordinated the delivery of work during crisis. And it needs to be said, I suppose, the value in both that kind of strategic partnership piece, an ICS level, but also the real value in those local partnerships and thinking about local sort of borough partnerships and those relationships at that level to gain traction in the actual doing, as well as the strategic thinking and planning. We've heard as well from others, and certainly for ourselves in NCL, the need to embrace technology. I mean, it's been incredible, the shift to kind of digital by default across the last few months through absolute necessity, and the need for that kind of urgency and pace around that. So better utilising technology, whether that's the kind of, good old telephone, Zoom, conference calls, remote consultations, which has been incredible to see. And I think the crisis has stimulated that transformation. And again, linked back to the asthma registry for us in North Central London as well. And then, and we've heard from others today the real need to adapt and continue to learn, almost daily, really, through this pandemic. So teams from across the sector have adapted almost overnight, whether that's through use of space, processes, or approach. Learning about what works has been really important, given the changes in how we now need to work. And we'd done a piece of work with a range of our providers and some families about what's worked really well and what we can build on from the changes and innovation in this period, and things that we need to look at in terms of planning for the future. So that's been really helpful. And again, continued conversations with young people and families. Really important that we remain alive to issues affecting them. Experiences and worries now more than ever, I think, so that we can adapt and evolve to meet their needs. And certainly, as we've seen, sort of national pictures changing, thinking about, shielding lists and ceasing of those, thinking about testing and the issues there. Week by week, our young people and families are having to think about or worry about different things. And I think it's helpful for us to ensure that we remain really alive to those in the moment, so that we can address those as they come up through our communications and through our work, really, across our partnerships. I guess that's just a canter through some of our work in NCL. Happy to take questions or answer those afterwards, or be contacted. Thank you, Oliver.
Thanks, Sam. We may get a minute just for a couple of quick questions, but thanks for taking us through that, Sam. Now you had your hand up. Is there a question that you had for us?
I'm on now. Just quickly, I've been listening to the presentations and they're wonderful, but I was just wondering, has anybody thought about having a mobile skin prick or allergy testing unit, as they have done in Bristol, that would go around the borough and pick up? And it's probably not appropriate during COVID, but it may be an innovation that may be useful later on.
Yes, I think a very broad point there now, I think, for all of London. I know certainly skin prick testing, allergy testing is one of the things that we're looking at, not sort of indirectly related to asthma, relevant, but slightly indirectly related, but certainly is one of the things we're trying to look at in terms of, particularly in terms of COVID and backlogs of waiting lists, etc. So yeah, it's an interesting suggestion for a solution. I don't think anyone's specifically done it yet, but certainly it will be. I'm sure will be something that all areas will be looking at. Just one point. It seems odd asking you questions about NCL, Sam, when I kind of know the answers myself already. But a good one, I think, would be your suggestion or advice about how would you develop an inclusive asthma network with strong engagement?
Thank you, Oliver. I think part of NCL's solution to that was developing our strategic plan. So before we did that, the engagement of key stakeholders in raising asthma as a key issue directly, being really clear about what the links are for that particular bit of the system and asthma, so that they understood their place in that. And asking them to be part of developing a plan rather than develop a plan and then try and retrofit partner organisations into that. I think so. Starting at the start has been really helpful, and being really clear about the relationship with different bits of the system and our asthmatic population. I think the other key piece for us in NCL, in terms of the development of the network and increasing partners, kind of non-traditional, as it were, partners around the table, was reaching out to those local borough partnerships and ensuring that we made clear how our asthma agenda aligned to local priorities. So ensuring that we were able to highlight to people how it was important for them locally. So we started by kind of asking people to come around the table, and towards the end, I think because of that, the local conversations at that very senior level, we've since had people asking to be part of the network, which has been fantastic. So I think those are the key things, I would say, Oliver, being clear with other partners that traditionally perhaps wouldn't have thought about asthma. I mean, I'm thinking about some conversations we've had with some of our early help colleagues in children's social care, and understanding the links between, socioeconomic background and asthma, and those in deprived areas being 2.5 times more likely to be admitted, which is, just not acceptable. And recognising then who else is working with those vulnerable groups and those children and young people and their families, and reaching out to them and making those shocking statistics really clear. And actually early help colleagues in NCL then absolutely saw their place in that, wanted to upskill themselves in understanding what they needed to do to support their families to reduce that statistic.
Fantastic, thank you. Thanks for that, Sam. So yeah, if anyone has any further questions, please drop them into the chat. And if you want to discuss it offline in a more detailed way, please do get in touch with myself or Sam. We'd be happy to talk to you about our experience. So we move on to Northwest London now, and we have Stephen Goldring and Claire Galvin, who will be talking to us about the work in Northwest. So over to you guys.
Hi, thanks very much. I hope you can hear me okay. They seem to be building something outside this window, so I apologise if there's background noise. Next slide, please. So, and thanks to Claire Galvin, who do feel free to chip in. It's very difficult to follow all these great acts. I will try. I'm going to keep it relatively brief and just give a flavour of some of the things that have been happening across Northwest London. We were at an embryonic stage with our first network meeting in January 2020. We all rather quaintly had coffee, sat in a room, we met, we used pens and paper. It was fantastic, very exciting. And then, of course, went into sort of hibernation and re-emerged with our second meeting in July, with, of course, a different set of priorities, or priorities that have been realigned, and a whole load of mayhem. Subsequently, we've met very often, actually, and MS Teams has really enabled some great team working, and Inner and Outer London have some short weekly team meetings to troubleshoot particular issues and try and problem solve, which are very effective. And we've had we've met every month, July, August and September, to try and catch up and build our plans, our strategic plans, so that we can get to a place where we've got a really clear vision of where we want to get to and how we're going to get there. Next slide, please. So at the moment, this is our working network plan, and I'm not going to go through it in detail, and it's going to evolve, and it needs all the sort of detail putting on it, how we're going to get there. But our focus is on the patient pathway, schools, training, building the network, and making use of digital resources, and of course underpinned by CYP engagement, gap analysis and peer review, which we've got coming up, which I think is going to be very helpful to learn from others, and making sure we're using WYSIC, which is a great data resource, to kind of make intelligent decisions about prioritising interventions. Next slide, please. So, thinking about sort of priorities and achievements with the kind of COVID hat. So I think the first thing right now is it's all about COVID preparedness, and I'm really grateful to John, Roland and Giles for their work on the SDEC pathway, because I think that helped us to kind of look at and think about our same-day pathways, and that's been terribly helpful in responding to Gold Command Northwest London's loud requests for pathways. I think the second thing there is about developing risk assessment tools, and I think this is one of the key priorities for us now, and all of us in relation to COVID, as we have to adapt to virtual and non-face-to-face working. So we're thinking about this in terms of both how do you risk assess individual patients and make decisions about their treatment, and secondly, how do you risk assess interventions at a practice and a PCN level? What's the best way to use the limited resources that we have? It's a very clear message, Claire, forgive me, from kind of the higher echelons, that there's no funding for additional staff, and it's about using our resources differently, which I of course completely agree with, but you do need that sort of pump priming resource, and we're really thinking very carefully about how we're going to target our interventions to the right place. And we've got a project that's using WYSIC, the whole system integrated care tool, to do that, which is unfolding. I'm now going to talk in a little bit more detail about the next 4 items. So if you have the next slide, please. So the first thing is, I guess, that was a direct response to COVID, was that we developed an asthma script for school nurses, and thinking what Sam Rostrom was saying about conversations, this really links very nicely with that. So we identified, obviously, that health access was delayed for children with asthma, and that CYP and families had fears of attending hospital or their GP practice. And so we developed a proposal to proactively call known asthmatics on the school caseload, with an aim to support school nurses to provide first-line asthma health promotion, so that CYP families could manage their asthma, and risk assess whether they needed directing to their GP or an asthma specialist. And actually, this was through CLCH, Central London commissioning healthcare, and it included both boroughs, both within and out of northwest London. Next slide, please. So I think the principles of this, and I think I learned a lot through the discussions personally, is that this was a health promotion conversation. We based this on the principle from BTS that every asthma consultation is an opportunity to review, reinforce and extend the patient's knowledge and skills. It's important to recognise it's a process and not a single event. And brief, simple education linked to goals is most likely to be acceptable to patients. And I read that out in detail because obviously there was a lot of tension when we were writing this guidance about, well, you know, you've got to ask every last question about asthma and get every last detail. And the pushback from school nurses, well, hang on, we're not asthma nurse specialists, we're school nurses. And what we're really good at is having risk-based conversations and thinking about public health and the wider family. And that was a terribly helpful way of framing this piece of work. Next slide, please. So the script has a flow of collecting demographics, then a conversation, then a risk assessment, followed by advice and actions. Next slide. Now, this is just to highlight the key questions. Once you've got past demographics, this is the list of questions that we encourage the school nurses to ask. And I guess you can see that at the top we've got the GINA asthma control questions. We wanted to get we thought it was essential that asking about asthma control was in there. But given the choice between using the children's asthma control test, we opted for GINA because it's so much simpler, and the feedback is that this has worked really well. And just having an objective way of asking about control has been very valuable. Obviously asking about smoking at home, and then the key things: do they have a plan? Can they talk through the plan? You know, can you have a sensible conversation about how they know how to use this plan? Do they know about their medications? Are they confident with their inhaler technique? Any problems collecting regular medications, which of course is an issue in relation to COVID, and then knowing what to do in an emergency. So we kept it pretty brief and followed this conversation up with, if we go to the next slide, a risk assessment tool. So we based this using evidence from BTS and GINA, and a little bit of in inverted commas expert opinion, and came up with a kind of traffic light system of reassuring factors where essentially everything was all good, factors of concerns where may need input from their usual health professional, be it the GP or their asthma specialist, and high risk factors. You can see how they pan out there. And again, feedback's been good, but this has just been useful for asthma nurses, for the school nurses to frame their level of concern. Okay, next slide. And of course, we supported this with some resources within the package about what to do, and of course there was a number of educational sessions that we did on virtual platforms to make sure that school nurses were all trained up on how to use this. I'm afraid I don't have numbers of times this has been used, but I've got a collection of assessments that have been done for children. There's been probably a leaning towards children who have got social issues or on safeguarding plans, etc. And I think the feedback has been particularly helpful for that group. So thanks to Helen Blackburn for that. And we've gone to the next slide, please. So I want to mention asthma-friendly schools. So I guess the key point is that in August, we agreed that this was a key aim for our network. We've done a gap analysis of asthma-friendly school status across Northwest London, and it is patchy, if you like, with some boroughs being very far ahead and having a whole system in place, and other boroughs having virtually no policies or procedures in place or relationships with the schools, and being very early on in that journey. So we've a lot of our network meetings have been spent getting agreement as to what would an asthma-friendly school look like in Northwest London, and how are we going to do this. And it's great to hear and to know that actually everyone's signed up to this, and we've kind of got essentially a unified approach. We maybe controversially have gone for a single school asthma plan, basically a plan which says what you do in an emergency. And so the training is all around managing an acute asthma attack. And we have an asthma attack poster which outlines what to do, as opposed to the emphasis being on individualized patient plans, which of course I know is slightly at odds from other approaches. The challenge, of course, is when we speak to the sort of going through Gold Command and the resource allocation, is trying to align this program to the burden of COVID priorities. This is obviously a longer term project. I know a little bit of resource would go a long way in terms of administration for this, and time in job plans across the region, but people named here have been absolutely fantastic in driving this forward, and we're definitely making progress. Next slide, please. Now, another innovation that's I think COVID related is around virtual group consultations. Been doing this on a sort of pilot basis with a wonderful GP called Yasmin Razak, who works in inner London, and Sharon Hall, who I think is on this call, and a few other people, and we've been piloting group asthma consultations, in particular for adolescents, and there have been a number of different activities, but if the technology works, we may be able to hear from a 15-year-old. If you can play the audio piece now, great.
Hello, my name is Issa. I'm 15 years old and I was a part of both online and face-to-face group consultations run within our local GP surgery and Imperial. Between these two, I had a routine asthma consultation with my GP to learn more about my condition. Due to my experiencing of these 3 consultations, I am here to analyse what worked well for me as a patient. In a face-to-face meeting, there must be an appointed place, time, and other arrangements to be made, which I found to result in unnecessary stress on the doctor, and this affects how much I get from the consultation as a patient. The digitalization of these consultations give you as a patient a more relaxed and meaningful consultation, as while you can both be anywhere and receive important information to aid with your health. The doctor can also be anywhere, therefore less formal and strenuous on both you and the GP. Despite this, the face-to-face group consultation was pulled off quite well. There are a handful of other people with me, and we all submitted our experiences around asthma quite anonymously, using sticky notes. As this was our first session, this worked quite well, and I felt satisfied with the information I attained. I left feeling quite confident in my understanding of what I thought was just asthma, and I was sure that other patients had the same feeling too. With the online video group consultation, I found the best thing to be the feeling of personalization through the screen. My GP was also able to zoom in an asthma specialist, which was rather easy through the online platform. Though I wasn't physically present, the specialist taught me more about my condition, and I learned that rather than asthma being the main problem after strenuous activity, it was something called dysfunctional breathing, which I'd never really heard of before. I was taught about how it worked and how to deal with it, as well as understanding the why in between. With our generation's general ability with computers, I found this information much easier to store and keep safe while keeping up with the conversation. This, along with the presence of a specialist, served to strengthen the feeling of personalisation, and I felt I left with much more information than after leaving the face-to-face group consultation. Actually, being in my own space made the consultation personal to me, and it felt more relevant. I also learned from the questions by other patients on the call with me, giving an extension to my own understanding and knowledge of asthma in general. I found this profoundly better than the face-to-face one-to-one consultation I'd had only weeks before with a friendly but clearly tired GP who decided to work a little overtime just for me. The information I received from this face-to-face consultation was minimal, and I left feeling as unsure about my condition as when I had entered. Some quick tips and tricks are having an icebreaker.
Stop that there now, I think. Okay, back to the slide. So you can obviously very eloquently put, and I think that reflects my own experience of virtual group consultations. They're very satisfying, actually, and I've only done them with adolescents, but I think they're absolutely fantastic. And you can have it's just remarkable how meaningful they are and how much impact you can have. So I think this is probably one of the great opportunities of COVID to link in primary care, secondary care, and tertiary care, and actually, move into the next century with these resources. Next slide, please. I think this is the last thing I want to mention. I guess because it feels like kind of progress. Of course, this is something other people may be familiar with, but another achievement of our network meeting was to agree a post-attack salbutamol use guideline, which is basically not a weaning, in inverted commas, guideline, and it is written there how to manage your asthma once you've been discharged. And I think it's great that we've agreed this as a network, and the next step is to get this into all our our guidance, our protocols. I know here in Hillingdon we're just thinking about we've got to redo all our documentation and a big amount of training. So, but we're all saying the same thing at the same time to all the new doctors, nursing staff, A&E staff, because of course we've been saying this like some kind of crazy mantra up until now. So I'm pleased that we've achieved that. Next slide. Yeah, so that's it from Northwest London. So if there's any questions, happy to take them. Thanks very much.
Great, thank you so much, Stephen. So just a comment from Richard that came in the chat, which was relating to the likelihood that transmission of common viral illness in schools, given the drop in presentations of asthma and the improvement of asthma control during COVID times, seems that there's likely to be a sort of significant impact of circulating viral illness in terms of managing asthma, and obviously schools being a real sort of focus for that. And his question was, is there anything that can be done through the asthma friendly schools work to address that within schools to support reduced asthma exacerbations? If that's something you'd thought about.
In relation to COVID?
More broadly, I think. So taking the lesson from the COVID period and incorporating that moving forward.
No, we haven't looked at that, I'm afraid.
Yeah, I think, and certainly not something that had crossed my mind actually either. We were in early stages in Camden with regards asthma-friendly schools, but certainly, maybe for all of us who work or have asthma-friendly schools programs, that's perhaps something that we can think about incorporating. Richard, did you want to come in? I see you popped your hand up there as well.
Yeah, so I suppose my question is, I think we've seen this vast reduction, and there has to be some element of what goes on in schools that increases that transmission and causes a lot of our admissions. And so, thinking about what we will have to learn and take out of COVID is, what can we do in the schools to try and reduce that? And I think it's, class sizes, is it hand washing, is it the environment, the book corners and things like that that are full of house dust mite. And I'm sure that I think as paediatricians we have to be fighting to reduce those school-based asthma attacks.
Yeah, fantastic. So thank you very much, Stephen, for that presentation and for the fabulous work that's going on in Northwest. Sorry, there's not time to ask lots of questions here. If you do have any questions, for Stephen or Claire with regards to the work, please just drop them into the chat, and I think Stephen volunteering you to just pick up if anyone does have anything to ask. So thank you. So we'll move. That concludes the update section from the STPs. Sorry, can I ask everyone to unmute, please? Fantastic, thank you. So our final presentation of the day. So we're talking about back to school and in the time of COVID. So I'd like to welcome Heather Robinson and Emily Guimont-Farry, who will be talking about some of the work from Newham and Elft. So over to you guys.
Hi, Christine, can we have the slides up, please?
You're not sharing your own slides? I can do them. That's no problem.
Is that all right? Thank you. Because we're on a big screen from here, so we can't share it from a screen. Thanks, Christine. Hi all, I'm Emily and I am the Children's Community Asthma Nurse for Newham.
And my name is Heather Robinson, I'm the school nurse, but I'm the Transformation Lead for Children's Health 0-19 service in London Borough of Newham.
So we've been asked to talk about back to school, and we're going to put a little quick disclaimer up. So as with everything, as we know from all the talks today, everything related to COVID-19 and the information available is ever changing. I can't keep up with it. So keep in mind that these slides go with whatever the latest government guidance is. So we're in September, all our children and young people have now returned to school. Shielding was paused on the 1st of August 2020, despite what a lot of our families think, and very few children remain on the shielding list. Should they need to shield if rates of disease rises in local areas, so for like local lockdown and things like that. If a child is on that list, they will have been advised by their specialist. I think that's really important to know. The latest evidence suggests that the risk of serious illness for most children and young people remains low at this moment in time. So I think a little bit of background with COVID-19. So it's had the opposite effect of the one that I think we were preparing for at the onslaught of COVID. We expected a high incidence of infection due to asthma comorbidity, but in actual fact, we've seen all the slides today and at the King's presentations for those of you that are there, that in actual fact, the UK and overseas saw a significant drop in emergency attendances for asthma between March and April this year, August this year. The reasons aren't yet evidence, but chatting amongst specialists and having listened to all the conferences, there's thought to be around 3 main factors, although there are other things at play as well. So improved adherence to preventer medications. In Newham, we had an increase of 138% in preventer prescriptions for children and young people in March 2020 compared to the year before. People were frightened and they started taking their medication. 2, no school attendance, so decreased physical activity, reduced availability of respiratory illnesses. So many of the common triggers were reduced for the number of children. And 3, air pollution. As you've heard, Newham is particularly bad for this. It dropped significantly over lockdown. I'm sure all of you have seen the satellite images and cleaner water and all of that kind of stuff. So sadly, rates are now coming back up to pre-lockdown levels just as the children are going back to school. And that's a lot to do with the fact that we're being encouraged to take alternative methods of transport apart from public transport, reduce public transport, so people are getting back in their cars. And importantly, the risk of COVID-19 infection and illness is low compared to the risk of not treating the asthma. So there's a greater risk of fatal asthma attack if children and young people don't seek help because of a fear of COVID-19 and not going into hospital because of that fear. So asthma care in schools should be business as usual. So as you've heard before, as we've been talking about, all these children should have a personalised asthma action plan. Okay, we know that's not happening, and we will come on to that a little bit later as to what's happening in Newham. A reliever inhaler and the correct spacer for them. Every school should have, as an absolute minimum, an asthma policy, an asthma register, trained staff and asthma leads, an emergency kit and consent to use the emergency inhalers. So why does the risk of asthma attacks increase when going back to school, and what impact could COVID have? So seasonal colds, they're spending more time indoors, so it's a definite con. They've spent up to 6 months apart, so they're naive to a lot of those. But on the pro, there's better hand and respiratory hygiene. Even my 3-year-old tells me to sneeze into my elbow and cough into my elbow. She's very good at telling me that. A cleaner environment. So schools have put in better cleaning facilities on a more routine basis. Older children are wearing face masks and face coverings. Social distancing is happening and bubbling is happening, and self and household isolation if there are symptoms. So the kids that would have been dosed up with a bit of cow pollen sent into school now are being sent home to isolate because it might be COVID. Dust mite and seasonal allergies, so increasing exposure as more time spent indoors. But there's a cleaner environment. Again, there's that increased rate of cleaning, children wearing face masks and face coverings. Preventer inhaler routines disrupted. They've spent up to 6 months out of normal school routines, and what we know historically is when the children go on holiday, they forget to take their inhalers and bits and pieces. Conversely, what COVID has shown us is there had been, whether or not that continues, is an improved concordance with their treatment. And then anxiety and stress, so an increased time spent away from school and their support networks of their friends. And a lot of them are very, very anxious and worried about COVID-19. And I've definitely seen a lot of increased phone calls from worried families about the COVID-19 situation and the numbers of children in bubbles and bits and pieces in the past 2 weeks. So Heather and I were talking about spacers. So thinking about the use of spacers in schools, although not an aerosol generating procedure, it's probably best practice not to be on the receiving end of somebody blowing out of a spacer. So where possible and where it's appropriate, maintaining that social distance, but supporting that child and young person to use their spacer. Standing behind or to the side of the young person, so that they're breathing away from the adult, but the adult is able to observe that valve moving back and forth, and listening for any whistles for the techniques, which we know is poor technique. Ensuring the room is well ventilated, there's a large enough space, they're opening windows, things like that. And obviously no sharing of spaces, which is absolutely, was the same pre-COVID. Storage, not storing in plastic, because we know that increases the static pull to spaces. So cotton bags are ideal, or things that aren't in close contact with plastic. Washing them, normally recommended half-termly or visually dirty if they're not in use every day. Making sure that spaces return to the child and young people after washing, and so it's labelled and appropriately back to the right person, and washing hands. Face coverings and masks. So government guidance should be followed where, when and who. But children with asthma, even some severe asthmas, can wear face coverings and masks if they're comfortable to do so. They are excused if they're on public transport and bits and pieces, but actually we're finding a lot of our families are keen to wear them. If it makes breathing difficult, it could be due to uncontrolled asthma as well, but it's often due to the type of face covering that they're wearing. So we say if they want to wear them, practice wearing them for short periods of time and try the different types. Sometimes cloth are more difficult to breathe through than the surgical type masks. The benefits, well, there's a barrier between your triggers and you. There's an element of filtering the air, so warmth and humidity, potentially of mold spores, depending on what size micron they are, the dust, the pollen, the pollution that's around them. It improves respiratory hygiene, it warms the air, and anecdotally, our children and parents are reporting an improving symptoms since wearing face coverings. I think a lot of that is due to the humidification that comes from doing that, as we would, encourage them to wear scarves in the winter and things like that. So there was a question in the podcast that I did with Oliver about cleaning of school spaces, and should people be worried? And I think that was a concern, particularly as we know that chemicals can cause a reaction. So we asked Joanna Fury from the National Heart and Lung Institute at Imperial College what her thoughts were, and her thoughts were, while professional cleaners often report respiratory symptoms such as cough when they're at work, we believe this is due to the process of applying the product, and particularly sprays. The symptoms are thought to be due to irritation. There's no evidence to suggest that a newly cleaned room, even when strong chemicals have been used, will have sufficiently high levels of cleaning agents lingering in the air to trigger respiratory symptoms, but it's probably a good practice, all things being equal, to open the windows after cleaning. For those with well-controlled asthma, strong smells, including bleach, do not generally trigger asthma symptoms. Conversely, the increase in frequency of cleaning in schools may result in a reduction in virus transmission between children, viral infections being a common cause of respiratory symptoms. I think given the level of new referrals that we're all seeing, certainly on Twitter we've been talking about it, it's 50-50 as to whether that will happen or not.
Okay, so Newham have been looking at a new approach to asthma care in our schools. So a little bit of background. We estimate there are around 6,000 children and young people in LBN who have asthma, and we have a lot of suboptimal housing. We have damp, mould, overcrowding, and we're in quite a congested area. We have quite a lot of industrial traffic, so pollution. So we know that everyone should have a PAP. We know that you're 4 times as likely to have hospital admission if you have a PAP. But they should be completed in primary and secondary settings, but they don't always make their way into school. They're not always completed. They're not always reviewed annually. So we had a look at the number of referrals that were coming to the school health service from schools for PAPs, and it accounted for 20% of our referrals. Now, when you consider that school nurses are somewhat jack of all trades, we work with safeguarding, all long-term health conditions, emotional health and well-being, healthy lifestyles, the list goes on. To have 20% of those to be for referrals for personalised asthma action plans, when in fact we're not, they should be completed in other environments, that's an awful lot of referrals to receive on an annual basis. And what it felt like was that we were mopping up for a wider system, and we actually had evidence that in some schools, school staffs were writing PAPs. So LBN was already working towards all schools being asthma friendly, and we were already providing regular asthma management training for school staff, but we weren't achieving the reach that would really be necessary to create safe asthma school environments. So we wanted to try and shift our focus from us completing the PAPs to actually supporting the schools being asthma friendly. But due to limited resources and capacity, we really were stuck in a firefighting mode. So we certainly still felt that children need PAPs, and like I said, we were mopping up for that wider system. We also found through audits that PAPs and any individual healthcare plan, so an IHCP, can take multiple appointments. So we had a high was not brought rates, or we had parents, children, young people coming to the appointments with the wrong medication or incorrect spaces for their age, for example. You have the time that the appointments take to arrange, the associated documents, and then sometimes we weren't actually completing the PAPs because we've already identified we're not necessarily the best people doing that. We spent a lot of time chasing them from the wider system. And we all know this is all when they should be are better completed elsewhere. So myself and Emily both go to the Pan London Children and Young People Asthma Network meetings and the NEL meetings, and we had the pleasure of hearing about the work that was taking place in Hillingdon, and this was in November of last year, so the presentation just before us. And we really felt inspired to localise this way of working in Newham, and we got to work. But then obviously you can see from the time frames that there was a global pandemic. and our focus was somewhat taken elsewhere. But myself and Emily really and some other members of our team and our working group, we recognised that at that point, I guess we didn't know when we would be returning to school, but we knew whenever it was, there would be a lot of anxiety for everyone, and we knew that there would be a focus around asthma because of the respiratory associations, although we now have evidence that perhaps wasn't such a worry, but at the time it was. We knew that there would be a real worry for our parents, real worry for the schools, and this would result in increased workload for public health services such as school health services. So we set to work training, and again, this was mentioned in Rita and Linda's presentation, and Tori also touched on it. So we trained 40 asthma champions across the health visiting and school nurse workforce. So that was Emily and her colleague Chloe and Alison trained 40, and we started with a voluntary process. We sort of said, who really has an interest in this, and that kind of got us around 80%, and then we kind of touched on other people and said, actually, this really is pertinent for your role. So we put it out as an advert. We really said we want people who are inspired, passionate, and kind of this is a responsibility that will come with it. So it will be troubleshooting, training for the wider workforce, support for families, and training for school staff. And we met virtually with Hillingdon, which was brilliant. So thank you, Alison, for that. And met with some of the school staff in Hillingdon, which was really, really useful and kind of got us thinking even wider. We have a whole suite of materials for schools to use, and I'll talk about them a bit more. We took it to both of our governance boards, and we have had this approved all in August. And we approached a handful of schools to join us on our journey. And we have launched the whole school asthma approach for schools in Newham this week. So what is the project? So what we will do as a school health service and as a health visiting service is we will issue an asthma action plan